Good evening, everyone, and a very warm welcome to all those who have joined us here today for the IAPTCB CME. And warm greetings on behalf of IAPTCB team. And I welcome you to the online CME on allergy. It's been a very tough time with the resurgence of COVID, and we're seeing that meeting like before, like in the pre-COVID times, is becoming more difficult now. And it's an endeavor from IAPTCB to ensure that academics continue despite the unprecedented circumstances that we are in. And we're trying to balance a physical meeting with an online event. And I request seek your support in the months to come as well. Please share your comments and suggestions on the the President IAPTCB to please give his inaugural remarks. Dr. Arjun, please.
Good evening, all of you. At the outset, let me welcome the Central AP member, Dr. Narayan Reddy, Dr. Ravi Kumar, Dr. Narari, and Dr. Yashwant, and our secretary, the entire EB team, and all the participants, and the noted allergologists, pediatric allergists from our city. At the outset, on behalf of IAPTCB, I would like to pay our homage and tributes to our late Professor Dr. Amaresh, who passed away day before yesterday night. So he's been a noted teacher, professor, a good pediatrician, and a good human being. So, and then moving on to today's CME, since we are covering all the subspecialty chapters, today's CME is focusing on pediatric allergy diseases. And in fact, we've successfully conducted a national Allercon conference during a tenure of Dr. Narayan Reddy and me as secretary. A 2-day exclusive Allercon, which was hugely successful. And then we went on to start the allergic chapter of the Telangana state as well as Twin Cities. And as you all know, the allergic diseases are on the rise because of increased urbanization and industrialization, and also changing lifestyles. And also allergy is occupying a big portion of our practice for every average pediatricians. And thanks to the efforts of the allergologists from our city, Dr. Arif, Dr. Narayan Reddy, Dr. Suman, Dr. Pavan, Dr. Surendranath, and Dr. Spurti, Anandavani, and all others. In fact, so many have done their fellowship in pediatric allergy, and they are practicing pediatric allergy, and they are a force to reckon with in a national subchapter also, in the allergic subchapter. So, and also our Professor Nagarajan has been a guiding force for our pediatric allergists from the city. He's been like a father figure for pediatric allergy all over the country. So, and also IAPTCB is committed to giving opportunity and the opportunity to speak for our local faculty. We have a good number of young dynamic speakers who excel in their public communication to the members. So I welcome all this for academic feast. We have a good mix of the seniors and juniors. Seniors, Dr. Arif is there, Dr. Narendra, Dr. Kedar, and the youngsters also, there's so many are there, Dr. Suman. And our lead for this CME is our Dr. Suman, who is our EB member. Dr. Srinivas Jakka is another pediatric allergologist and pulmonologist. So don't want to take much time. Let's go on with the CME. But I would like to request you all, kindly please attend the vaccine decon. We made all the arrangements, and there won't be any hassles in attending the conference. It's more or less an open air auditorium, not exactly a totally closed door facility. So we are assuring all COVID protocols there. Please come for the conference in big numbers and make it a huge success. And as you know, 300 plus have registered for the conference. because my appeal is any pediatrician who is attending his clinic, seeing his patients, has every reason to attend our vaccine recon, which is being put up by PATS as well as TCB. Thank you all. Over to Dr. Suman, the lead for this CME, and
Sir,
take over and conduct that wonderfully.
Thank you, Dr. Arjun. Before Dr. Suman starts, may I now request Dr. Ravi Kumar, Central Zone Vice President from the state of Telangana and our own Hyderabadi. Sir, please say a few words before we begin our session today. Dr. Ravi Kumar, please.
Yeah, good evening. Thank you very much for inviting. Regarding this allergy, this is the old one. Only thing, a better understanding now we are having, and a better facilities to understand the immunology and the immunol complex. So that was the reason today it is in the raise. Probably it is going to cure many diseases which are till now we are not able to do symptomatic treatment. So I only hope with like this type of CMEs, all the society and all the doctors are going to treat the permanent solution for this allergic or immunology dependent diseases, whatever it may be. So thank you very much. Because I am driving, I don't think I can continue for a long time. But I will, after closing this, I will again come back into the web. Thank you very much, Arjun and your team.
Thank you, sir. Thank you. And thank you for joining despite you driving as well. Hope you're safe. Now, may to Central IAP. If we have Dr. Narahari and also Dr. Yashwant around, please let me know. Else, I'll request Dr. Narayan Reddy to please address us on behalf of Central IAP. Of course, we'll hear from him in the debate later on in the day. Dr. Narayan Reddy, sir, over to you, please.
Good evening, everyone. Hello, I'm audible.
Go on. You're audible.
Yeah, good evening, everybody. Because allergy is increasing. Earlier used to have when post-graduation infections were main common allergy hardly used to see. Now allergy is increasing. Infections are still persistent. So if pediatrician have good practice means has to have the rule of three. Number one, should know good knowledge of vaccination, good knowledge infectious disease and allergy disease. Because three, if you know, you can have good practice. Because most of 90% of OP are related to three only, roam around vaccination, infections, and allergy diseases. Because allergies are increasing, all skin, GIT, asthma, allergy rhinitis, food allergy are increasing. So all pediatrics should be aware about that. That's why this CM you are conducting to sensitize all practicing pediatrician. So how to diagnose, how to give in-time treatment, how to decrease the suffering and give good quality treatment. Thank you. All the best. Thank you.
Thank you, Narayan Reddy, sir, and I convey regards from the other two Central IAP members as well. All right, so now it's time to hand it over to Suman. Please take us through the journey over the rest of the day. Tell us what is in store, and over to you, Suman.
Yep. Thank you, Sri Krishna. I welcome you all to IAPTCB Allergy CME. This is a part of a regular program of regularly updating ourselves. And IAP Allergy chapter as of now is headed by Dr. U. Narayan Reddy under the guidance of Major Nagaraju sir. And we are all a part of it. We have got a lot of young and experienced allergologists in Hyderabad, unlike what it was a decade back. So what we felt was we have this entire team of speakers, which is blended with experienced people who have got enough knowledge in a field of allergy, and as well as young speakers who are coming up to give them an opportunity to express themselves. Their energy levels are quite good. Today we are going to experience both of them. And secondly, what is the importance of holding an allergy CME for a general pediatrician? See, coming to the practice out here, if you can see the last 1 to 2 decades, the infection rates have drastically come down. You could see in summers where our general wards used to be full with GE cases is hardly filling up right now. And the regular infections have gone down drastically. The lifestyles of people have changed drastically. And what we could see, which was a rarer cases of allergy have become quite common. I think if people are saying we are practicing pediatrics, then you're unlikely to miss a case of allergy. So the unlikely to, not to see a case of allergy. So your allergy cases have increased by almost 10 to 20% in the last 1 to 2 decades. So if you want to practice pediatrics in a longer run, allergy should be a part and parcel of your practice, and we should know how to recognize it, how to manage it, and how to follow it up on a regular basis. And as far as allergies is concerned, if you could say it, the challenges which a general pediatrician faces nowadays, thankfully, because of the lot of IAP initiatives starting from Sudarshan Reddy, people are sensitized to asthma. But every asthma is not allergic. That is something which we need to keep in mind. How to differentiate different asthmas is becoming a challenge. Now people are accepting, pediatricians are accepting asthma, but they need to know how to differentiate different types of asthma, how to manage, and how to go forward. That is something which we need to keep in mind. And there is a lot of other comorbids of asthma. People, because one size doesn't fit all. You give a same regimen treatment, it doesn't work for every case of asthma, because there are a lot of comorbids associated, and asthma itself is of different types. It's a dynamic disease. So you need to understand very basic of how it evolves. And not only that, because allergy is something which is connected to the entire body. It is not only connected to certain organs like, your respiratory tract or something like that. So you'll have a lot of skin allergies, you'll have urticarias, which sometimes become very chronic, and it becomes very difficult to manage. As a general pediatricians, if you are practicing in summer season, you'll see a lot of cases of urticaria, especially acute and chronic, which will be coming to us right during this period, which will be quite challenging for pediatricians, because simple medicines won't act, and we can't give steroids for every case on a long-term basis. So we need to understand what causes urticaria and how to manage it. And the most challenging, according to me, as far as pediatricians is concerned, is a food allergy, which is now drastically increasing. What we strongly feel is this food allergy is something misunderstood by most of the doctors and most of the parents as such. And especially for an infant who has food allergy, it becomes a real hell, because parents don't know what to give and how to manage, and they suspect every food to be causing allergy. And sometimes the investigations which we do, we depend on IgEs and an infant, and a small infant, which we are going to hear from Spurti right today. It's quite challenging. You cannot relate it directly. So these are all the challenges which we face as general pediatricians. It is better, we are sensitized towards it. We have got enough knowledge. We know how to handle it, how to give information, how to identify, and how to manage. And still, whatever it is done, whatever the diagnostics might be present, in a case of allergy, your history becomes the cornerstone. People who don't take a proper history cannot diagnose a case of allergy. Your history and your clinical examination becomes a cornerstone in management of allergy. So whoever want to practice a good allergy should know how to get a good history out of the patient, right from the past and the present, and do a proper clinical examination. That becomes a cornerstone for our diagnosis. That is what our speakers are going to say. So that would be the bottom line of it. And hope you people enjoy the session today. I won't take much time. I would hand over the first session of the day today is by Dr. Srinivas Jekka, and the chairpersons for this session would be Dr. Sugunakar Reddy and Dr. Vaidyam Chakravarti. I think they can take over. I think Srinivas Jekka would be talking about different types. All that wheezes is not asthma. You need to understand, when a child is wheezing and coming to a child, when a child is presenting as asthma, our role is to take a proper clinical history and do a differential diagnosis to rule out that it is not asthma first, and then diagnose asthma. So that is something which we need to practice. I think Jekka is going to talk more about it. And then we will have difficulty in asthma is when there are comorbids associated. So we will always have an association with ENT. What is the role of an ENT surgeon in management of asthma? Today we are going to discuss about it in the first session. So I would like to hand it over to the chairpersons. Try to welcome Dr. Sugunakar Reddy if he is available, or Dr. Vaidyam Chakravarti if he is available, to introduce the speakers first, and then I would ask Srinivas Jekka to take over, please.
Sugunakar sir, you can unmute and speak, sir.
Good evening. Good evening, Sri Krishna. I'm audible?
Yes, sir, you are audible, sir.
Welcome to the evening session. Today's session is on pediatric allergy and asthma. The first session is covering 3 topics by 3 different speakers: Dr. Arif, a senior pediatrician, and Dr. Alok, an ENT surgeon, and Dr. Srinivas Jekka. The first topic is asthma mimics. It's by Srinivas Jekka. He is well known to the IAPTCB. So I welcome Dr. Srinivas Jekka to speak on.
Okay, thank you, sir. Trying to share my screen. Is my screen visible, Suman?
Yes, it's visible, Jekka. You can.
And am I audible?
Yeah, you're audible.
Yes.
Okay. Good evening, friends, and welcome to the session. Today, I would like to talk about the differential diagnosis of asthma, conditions that closely mimic asthma. So, children with recurrent wheeze is very common in our OP practice. So, whenever we see children with recurrent wheeze, as pediatricians and as pediatric pulmonologists, we are faced with some common questions. Does this child have asthma? Could it be something else? And despite all the sensitization, there is still a stigma about asthma in parents. So we are faced with the question, will the parents accept the diagnosis of asthma? Shall we start this child on controller therapy, or shall we wait and watch another session or another season? So as we all know, there is no single diagnostic test for asthma. So when we see the child for the first time, we are not obliged to confirm whether the child has asthma or not if this disease is not very clear. Rather, my approach is to tell the parents the probability of their child having asthma. The probability can be low, intermediate, or high. And how do we come to that probability? The probability is based on factors that suggest asthma and factors that suggest alternate diagnosis, or ruling out the red flags. So what are the factors that suggest asthma? As we all know, asthma is characterized by cough, breathlessness, and wheeze. When we come to wheeze, most of the time the parents may be confusing wheeze with other respiratory sounds. And we also know that audible wheeze may be heard only in severe cases. So a wheeze documented by pediatrician in the notes is very important for confirming the diagnosis of asthma. And absence of wheeze on multiple clinic visits when the child is symptomatic will virtually rule out asthma. In children, in childhood asthma, the symptoms are usually exotic in the vast majority of children. Fortunately, chronic uncontrolled asthma is very uncommon in our country compared to the West. Then comes variability, which is one of the characteristic features of asthma, which means that the symptoms have variability in terms of diurnal variation or seasonal variation or variation in between different clinic visits. This variability can be assessed from history, or it can be objectively assessed by using spirometry. Atopy in child and family is very important in confirming the diagnosis. Response to treatment in the acute setting using a reliever and in long term using controller will confirm the suspicion that the child might have asthma. Now, what are the conditions that can mimic asthma? Any condition that can cause narrowing of the airway and cause cough, breathlessness, and wheeze can mimic asthma. The problem can be in the bronchial wall. There may be airway malacia. There can be bronchiectasis. The airway can be compressed by mass, lymph nodes, blood vessels, etc. There can be problems with the airway lining in conditions like cystic fibrosis or primary ciliary dyskinesias. There can be problems in the airway lumen due to foreign body, endobronchial tuberculosis or tumor. There can be protracted bacterial bronchitis. There can be aspirations. Others, which are more common, are recurrent viral infections, tuberculosis in our country, less commonly congenital heart disease, and recurrent infections due to immunodeficiency states. Now, let us discuss about the red flags or the features in the history and examination that suggest alternate diagnosis. Firstly, if the symptoms are very early onset, especially if they're there from birth, you should think about conditions like chronic lung disease of prematurity, ciliary dyskinesia, cystic fibrosis, etc. If the child has severe upper respiratory symptoms, you should think about ciliary dyskinesias. The child has abnormal voice or cry or stridor, we need to think about laryngeal or tracheal problems. The child has excessive vomiting, we need to think about GERD with or without aspiration. The child has dysphagia, we need to think about swallowing problems which may be associated with aspiration. Failure to thrive suggests GERD or cystic fibrosis, because failure to thrive or failure to gain weight is very uncommon in well-controlled asthma. And a persistent wet cough would suggest protracted bacterial bronchitis, bronchiectasis, recurrent aspirations, and ciliary dyskinesias. Because by default, the cough in asthma is a dry cough. And if a child has persistent wet cough, we need to think about this alternate diagnosis. Then comes breathlessness with lightheaded and tingling that suggests dysfunctional breathing or panic attacks. And next is persistent wheeze. By default, children with asthma have episodic wheeze with a relatively well period in between. But if a child has persistent wheeze, we need to think about airway compression due to vascular lymph nodes, etc. Airway anomalies like bronchomalicias, luminal obstruction due to foreign body or mucus plug. If there is strong family history of unusual chest disease, we need to think about cystic fibrosis and neuromuscular diseases. Focal signs in the chest on examination or focal radiological signs on chest X-ray or CT should make us think about congenital anomalies, foreign bodies, cystic fibrosis, bronchiectasis, etc. So let us go through some cases and see how we can diagnose this asthma mimics. So the first case is of that of a 1-year-old child. Child has recurrent episodes of wheeze and breathlessness from 4 months of age. Child was treated with salbutamol and budesonide inhalers with no response. On examination, child has tachypnea and subcostal retractions, and there is a diffuse monophonic wheeze on examination. So think about what are the red flags in this child, which we discussed earlier. The red flags include early onset of symptoms from 4 months of age, lack of response to medication, and a monophonic wheeze. The wheeze by default in asthma is polyphonic, but if there is a monophonic wheeze heard all over the chest, we should always think about large airway disease, especially in obstruction. So this child, chest X-ray shows hyperinflation on the left side. And when we did a CT scan, there is a compression of the lower trachea and the left main bronchus. And biopsy and histopathology showed that this is a bronchogenic cyst causing the upper airway obstruction. The next case is a 6-month-old baby diagnosed as bronchiolitis at 2 months of age. And a typical bronchiolitis, we expect the child to get better after 4 to 6 weeks, but the child continued to have persistent wheeze since then. Child received several courses of antibiotics and bronchodilators, but did not respond to the treatment. When we saw the child had mild retractions and diffuse monophonic wheeze again. So think about the red flags which we discussed earlier and which are seen in this child. The red flags are early onset at 2 months of age, persistent wheeze, not responding to treatment, and a monophonic wheeze. So we did a bronchoscopy on this child, and as you can see, there is a tracheomalacia and right bronchomalacia. So this child has tracheobronchomalacia. Coming to the next case, a 6-month-old baby, early onset of symptoms from 2 weeks of age, recurrent admissions for respiratory symptoms. And during this recurrent admissions, when they did chest X-ray, they were patchy, non-specific infiltrates bilaterally. The child had underwent bronchoscopy and CT chest outside, which was reported as normal. Child received several courses of antibiotics and bronchodilators. And when the child came to us, we took a detailed history. Mother informed us that the child had vomiting since birth. The vomiting ranged from small posets to large amounts. There was a history of poor weight gain. And the baby was unsettled and irritable between feeds, with a history of arching, stiffening of the back, clenching of the fist, drying up of the legs, becoming red in the face. All of them symptoms suggest of reflux disease rather. The symptoms are worse on lying down posture and improved on upright posture. So the red flags in this child are again early onset of symptoms, recurrent admissions, vomiting, and poor weight gain. And by the basis of the history, our diagnosis was reflux. We just needed an upper GI contrast study to confirm our diagnosis. The child had GERD with his respiration, started the child on anti-reflux medication, and the child is now thriving well. Case 4 is an interesting case, very common. 18-month-old child came with sudden onset of cough for 2 days, treated the referring pediatrician to the chest X-ray, started the child on antibiotics and bronchodilators for 1 week. As there's no improvement, he repeated a chest X-ray, and he rightly noted that the chest X-ray shows asymmetry and referred the child. So when we saw this child, when we looked at the referring X-ray, there is, as you can see, there is an asymmetry with hyperinflation on the left side, and there is also a mediastinal shift to the right side. So we repeated the chest X-ray, and the chest X-ray shows hyperinflation with mediastinal shift and segmental atelectasis on the left side. So what are the red flags? Sudden onset of cough with no prodromal symptoms. In a toddler where there is sudden onset of cough with no prodromal symptoms, you should always think about a foreign body. So no improvement after treatment, and we auscultated, there is a decreased air entry on the left side, and there is asymmetrical findings on the chest X-ray. So went ahead and did a bronchoscopy, and on bronchoscopy we could find a peanut at the origin of the left main bronchus, and that was successfully removed, and the baby got better. So the learning points are: any child with sudden onset of cough and breathlessness with no prodromal symptoms, especially in that age group, toddler age group, always think about a foreign body, especially when the examination findings or radiology suggest asymmetry. Now, case 5 is an 8-year-old female child, recurrent episodes of cough from 2 years of age, treated with several courses of antibiotics and nebulizers. And this is a common line for all the patients with no response. There's no weight loss. And again, a common thing is whenever the patients come to us, we take a detailed history. I take 40 to 45 minutes for first visit. Mother told me that the child has wet cough with expectoration, which can sometimes be greenish expectoration. On examination, the child had clubbing and bilateral crackles. So in this child, wet cough, clubbing, and crackles are the red flags. So we did a CT scan. The CT scan showed signs of bronchiectasis. The sputum was positive for Pseudomonas and Staph aureus. We sent our diagnosis was cystic fibrosis, and the genetic test confirmed the diagnosis of cystic fibrosis by delta F508 mutation. So this child had cystic fibrosis, and hence since then the child is being treated for that and remains well to date. Case 6 is an interesting case. A 2.5-year-old child seen by us 6 months ago. History of poor weight gain from 1 year of age. Recurrent episodes of cough from 1 year, for which the child was treated with antibiotics and nebulizers. From 2 years of age, child had increasingly worsening of breathlessness to the extent that at the visit, the child was breathless even at rest. So think about the red flag signs, what you could see in this child. So again, we take a detailed history. There is history of consanguinity in parents. The first child was admitted to hospital several times with respiratory symptoms from 2 months of age, treated with several episodes of recurrent pneumonia, or what was diagnosed as recurrent pneumonia. Unfortunately, that child died at 9 months of age due to a suspected pneumonia. Child was ventilated but didn't get better. Third child, mother was anemic in pregnancy and there was intrauterine death at 9 months. Fourth child is our current patient, and fifth child remains clinically well. So the red flags are poor weight gain, which is very unusual in asthma, lack of response to asthma medication, worsening of breathlessness and persistent breathlessness to the extent that child is breathless at rest makes asthma less likely, and family history of unexpected deaths and respiratory illnesses. So when we saw the child was hypoxic, tachypnic with minimal retractions. Chest X-ray showed a diffuse ground glass appearance, and a CT scan showed extensive ground glass appearance pattern with septal thickening, and the diagnosis was of an interstitial lung disease. Did a bronchoscopy, which showed a milky fluid positive for PAS, and our diagnosis was pulmonary alveolar proteinosis. This was confirmed by genetic testing, which showed a mutation for GM-CSF2-ARIA deletion, which is the receptor for GM-CSF. The child underwent whole lung lavage, and this is the chest X-ray after that. I saw the child last week, 6 months after the lavage, and the child remains well. The last case is a 1-year-old infant, came to us 1 year ago with cough, breathlessness, and wheeze. Child was treated outside with antibiotics and bronchodilators with no response. The child came to us with severe distress, did not respond to all the medications, the IV steroids and magnesium and aminophylline. And we took a detailed history again, once again. Mother gave a history that at 10 months of age, child was admitted with bronchiolitis-like illness. treated with HFNC and IV fluids. And during this episode, the adenovirus was positive from a PCR from respiratory secretions. So again, the red flags are persistent breathlessness, persistent wheeze unresponsive to treatment, history of bronchiolitis preceding the illness. And when we did a CT scan, what you could see is you could areas of low attenuation due to hyperinflation and oligemia interspersed with normal lungs that gives a mosaic appearance. You could see bronchiectasis changes and bronchial wall thickening that suggests of bronchiolitis obliterans. So this is one of, if you see an infant post bronchiolitis with persistent wheeze or breathlessness, and with this findings on a CT scan, you should always think about bronchiolitis obliterans. So summarizing what we discussed so far, early onset favors alternate diagnosis, whereas a later onset favors asthma. Persistent symptoms, especially wet cough, suggest alternate diagnosis, whereas episodic symptoms and variability of symptoms suggest asthma. Definitive history of wheeze, especially documented wheeze, favors asthma, whereas no definitive wheeze suggests alternate diagnosis. Atopy in the child and families favors asthma, whereas lack of atopy favors alternate diagnosis. Similarly, no response to treatment, severe upper respiratory symptoms, excessive vomiting, failure to thrive, clubbing, cyanosis, focal signs on examination or radiology favor alternate diagnosis. So this is the most important slide of my talk. So it seems very simple, but in reality, what are the difficulties in diagnosis of asthma? So asthma is not a heterogeneous disease. It's a disease, it's a syndrome with varied combinations of cough, breathlessness, and wheeze. If you take all the symptoms together, it has a very good diagnostic value, but the predictive value of individual symptoms is poor. Combined with this, there is a lack of parental awareness of symptom recognition, particularly when it comes to breathlessness and wheeze. Unfortunately, we do not have resources with respect to time and objective testing. As discussed earlier, most of these conditions were diagnosed by us or at least suspected on the basis of a detailed history. And many places we don't have spirometry for objective assessment. More than that, lack of documentation. Whenever the child visits the doctor, lack of documentation of the wheeze, lack of documentation of signs of distress and response to treatment is one of the most difficult feature which makes it difficult when the child comes to me for a second opinion. Despite all the sensitization, there is still a reluctance among parents to accept the diagnosis of asthma. And therefore, there is also reluctance on part of the physicians to give the diagnosis to the parents. So the take-home messages are, asthma is still the most common condition causing airway obstruction. There is no doubt about that. However, there are many other conditions that can obstruct the airway and can mimic asthma. And these asthma mimics must be identified by a detailed history by identifying the red flag signs. And to identify the red flag signs, a detailed history and systematic approach is essential. And prompt recognition and referral will ensure optimal outcomes, not only for asthma, but also for this alternate diagnosis, whether it's a foreign body, a cystic fibrosis, bronchiolitis obliterans, or any of the conditions or interstitial lung disease, which I discussed earlier. A prompt referral will ensure optimal outcome. So the saying that all that wheezes is not asthma is absolutely true. And whenever you see a child who doesn't fit into the asthma phenotype, we need to look from a different angle and look at the red flag signs and see, can it be something other than asthma, and refer to a pediatric pulmonologist, and we'll be able to help you in that. Thank you very much.
Thank you, Jacob. Can you just
talk for nicely covering? Yes, Suman?
Yes, just a few comments, sir, on the talk. Thank you, Jacob, for the talk. Only a few things for the pediatricians who are there, who are really confused about diagnosing different cases of asthma. Only 2 tips from my end. If a child is well looking, and if a child responds to bronchodilator, there's a reversibility. Most likely it is a case of asthma. If the child is not well looking and not responding to a bronchodilator therapy, it is always better we look out for other alternative diagnosis to asthma. It's a simple tip which pediatricians can practice in the daily life. So Sugnaka sir, you can take over, sir. Sorry to interrupt.
Sir, thank you, Srinivas, for nicely covering how to differentiate asthma from the asthma mimics. You have extensively covered in your case presentations are very Nice illustrations. And there is one question regarding the alveolar proteinosis. Is it a regular lavage is needed or?
It's a whole lung lavage, sir.
Whole lung lavage. How frequent we are supposed to do?
It depends, sir. Some children require it very frequently, but some children require few times in a lifetime. So it's difficult to predict. So there are two variants in that. One is where there is antibodies to GM-CSF, where we can give GM-CSF from outside. So every month we can give GM-CSF. But if there is a problem with the receptor, like in our case, then the only treatment is lavage. So this child, I saw 6 months later, child is still doing well. So we monitor the child every 3 months. The child is becoming hypoxic or worsening distress, then we have to do lavage. So the answer is there is no definite duration which will tell us that you need to do lavage this frequently.
So how is the prognosis for this?
The prognosis is good, sir, as long as the parents can recognize the signs of breathlessness and hypoxia and come to us. Once we do a lavage, the child can lead a near normal life.
And in the most common practical setting in the outpatients is laryngomalacia.
Yes.
So, how, in your experience, at what age it will subside on its own? Are any medications to improve the laryngomalacia?
Laryngomalacia, they actually usually present with stridor, as we all know, and usually they get better by 18 months to 2 years of age. If sometimes laryngomalacia can be associated with GERD, which can make the malacia worse. If there is GERD, then we have to treat the laryngomalacia. But per se, there is no medical treatment for laryngomalacia. If the child has any apnea, feeding difficulty, or poor weight gain, then we should do a laryngoscopy, and then we can go for surgical intervention if that's needed.
If it is associated with hypocalcemia, we may supplement the calcium.
Yes, sir. We can do some calcium supplements.
Calcium levels are normal. Any other medication to?
No, sir. I mean, medically, that's the only thing we can do, sir.
No.
Of GERD and calcium supplement.
Thank you. Thank you, Dr. Srinivas. We'll move on to the next topic. Dr. Alok. Dr. Alok Rati. He is going to speak on the asthma and ENT disorders.
Dr. Sugnakar, one question to Dr. Srinivas. Can I?
Yeah, okay, no problem.
Yeah, Dr. Srinivas, is asthma a comorbid condition for COVID in children? One. Second question is the exercise-induced asthma. How common, how much percentage is there in pediatric population, and how to identify just only the exercise-induced asthma?
So there is first question. A well-controlled asthma is not any more severe comorbidity compared to any other person. So if a child has asthma and is well controlled with the controllers, he is no greater risk than any other child or adult, sir. However, if the asthma is poorly controlled, like any other infection, COVID can make it worse and they can have more severe illness. So earlier in the CDC, asthma was one of the high risk factors, but now I think studies have shown that it's well-controlled asthma is no more a significant risk factor for severe COVID.
Thank you. Next.
Second question, sir. There are two things. One is exercise-induced asthma and exercise-induced bronchospasm.
Right.
So exercise-induced asthma is where exercise is a trigger in a child with pre-existing asthma. And that's very common, sir. Exercise as a trigger is very common. Whereas exercise-induced bronchospasm, where there is only spasm or inflammation during exercise, particularly high severe exercise, and the child gets well once he takes rest. And the inflammation, underlying inflammation is slightly different from that of asthma. And if you're asking how common, there are no studies. I don't think there are many studies, but they're probably, if they're looking at adolescents and adults, particularly the incidence is anything from 10 to 20%, particularly people who exercise in cold and dry conditions, athletes with skiing and other places, or swimming due to the chlorine and other irritants in the water. It's in these athletes that it's more common, sir.
Thank you very much, Dr. Srinivas. Wonderful. Thank you. Go on, Sugnakar. Thank you.
Okay. Thank you, Dr. Arjun. The next topic is asthma and comorbids of the ENT. Is covered by Dr. Alok Rati from Ankura Hospital. Over to Dr. Alok.
Alok, you can take over.
Right. Is my presentation visible, sir, on screen?
Yes, yes, visible.
Okay, thank you. So good evening, everyone. First of all, I would like to thank IAPTCB for giving this opportunity. I will be covering ENT disorders and how they complicate asthma actually. So the reason ENT doctors are involved in management of asthma is because of the concept of unified airway. As we all know, upper airway and lower airway both have similarities in functional and anatomical aspects because they have a common goal of assisting in respiration. Okay, so any condition which can affect both upper and lower airway will definitely have more morbidity rather than any condition which is affecting only upper airway or only lower airway. So these common conditions are definitely the ones which we need to look up to when we have a child with poor asthma control. Okay, so majority, the main diseases in this group are allergic rhinitis, which forms the bulk, chronic rhinosinusitis, which is actually underdiagnosed most of the times, obstructive sleep apnea. These three form the bulk. Apart from that, we have vocal cord dysfunction, aspirin exacerbated respiratory disease, and GERD conditions. Okay, so allergic rhinitis is going to be quite well covered today in later sessions. I will be going through it briefly, touching the recent developments in guidelines, how are we treating them. And surgical management as such in allergic rhinitis is not much in pediatric age group, though there are surgeries described in adult age group. For pediatric, other than adenoidectomy, if it is somehow contributing in chronic rhinosinusitis or other aspects, we do it. But as such, it's not, there is no surgery defined for allergic rhinitis in pediatric age group. ARIA guidelines, we have at the moment guidelines moving towards collaboration of the mixing of guidelines with real world evidence. Basically, these are being developed using mobile technology and other technologies. And I think next level, we are going to get digitalized algorithms. These are basically patient-centric approach-based guidelines so that how patients react to their asthma symptoms and allergic rhinitis symptoms and how they choose the treatment options available to them. Based on this, these guidelines have been developed. This is a brief overview actually. So this is based on, again, visual analog scale, which treatment is recommended, which should be used, which should be not, based on the grade recommendations which were given in 2017, and then later this has been developed. So we have excellent presentations coming up later today, so I'm not going in detail, but this is a rough overview of the role of antihistaminics and intranasal corticosteroids or combination drugs. Okay. I'll be focusing much about pediatric rhinosinusitis, which is one of the important condition which can aggravate or make management of asthma really difficult. It is defined as a condition where you see two or more symptoms. One should be nasal blockage or congestion or obstruction or nasal discharge, other being either facial pain or pressure or cough. And we also need to have endoscopic or CT findings. Endoscopic findings could be nasal polyps or edema or purulent discharge from the middle meatus in the lateral of the nose. CT findings could be mucosal changes within sinuses or osteometal complex, like in this picture. These are the recent guidelines which have been developed by European Position Paper in 2020. They have been developing them regularly for like in 2012 and before the 2007. So these are recent updates, and there has been a major change in the management of pediatric rhinosinusitis. Now it's more towards self-care, self-education, providing digital access to health education materials, encouraging nasal hygiene, saline sprays, and if available, over-the-counter drugs. And if any child, if you are suspecting or we have a diagnosis of chronic rhinosinusitis, we should rule out presence of any adenoids. If we are suspecting adenoid hypertrophy, and the child should be referred for a secondary or tertiary care center for further evaluation. If not, no adenoid hypertrophy, but simple pediatric chronic rhinosinusitis, We can start intranasal corticosteroids, give it for 6 weeks to 12 weeks. If there's an improvement, then that can be used to manage the child based on step up and step down methods. Okay. However, if there is no improvement, then those children should be referred for secondary care or tertiary care centers. We need to know about the alarm symptoms like double vision or any eye symptoms which are extra nasal symptoms or frontal swelling, headache, neurological signs. Any symptoms which is going beyond the nose, those are like alarm symptoms. They definitely need a tertiary or secondary care center. What happens there is a child needs a full ENT examination, a proper formal nasal endoscopy, which would rule out and confirm what is happening inside the nose and beyond. So is it adenoid hypertrophy? Is it primary chronic rhinosinusitis, or it is neither of both? Okay, so if it is adenoid hypertrophy, adenoidectomy has to be done, and if symptoms have improved, referring back to primary care, managing medical therapy or senile irrigation or health education. If it is primary chronic rhinosinusitis, child needs to be considered to rule out any secondary conditions leading to chronic rhinosinusitis like cystic fibrosis, primary ciliary dyskinesia, primary immunodeficiency. If none of them, yes, appropriate medical therapy. Nasal steroids again form the main treatment role. It may be drops or sprays or rinses. Saline rinses is more encouraged in the present guidelines. And any treatment at least 6 weeks, at the time like maximum 12 weeks. If there is no improvement in 12 weeks, think of something else. We go for CT scan if there is no benefit with medical therapy to look for involvement of sinuses, because endoscopy will not give you detailed evaluation of sinuses in depth. It would be nasal cavity and openings of sinuses. So CT scan has a different scoring, which is Lundmecker scoring, which grades the severity of involvement of sinuses and nasal cavity. So based on that scoring, we have low LMS and high LMS. Low LMS, again, it would be just adenoidectomy followed by medical therapy. For high Lundmecker score, we go for adenoidectomy, and we also consider irrigation of sinuses to clear out all the obstruction and diseases in there. Following which, again, medical therapy is recommended. After this, if there is no improvement even after with adenoidectomy plus irrigation, then the next step is FES. Of course, it's done in older children. So ultimately, there are different levels of evidence for all these treatment regimens. Antibiotics, corticosteroids, systemic steroids, saline irrigation, adenoidectomy, and FES. Antibiotics as such, there is no high level evidence for short-term duration or long-term duration in chronic rhinosinusitis in pediatric age group. In fact, intranasal corticosteroids also do not have any high level evidence. Of course, the European position paper, the European position guidelines, which is the working committee, what they have still recommended is to use intranasal corticosteroids because of its proven anti-inflammatory effect and also its excellent safety profile in pediatric age group. Systemic steroids, there are no much studies, only 3 studies, I guess, proper studies. And one of those studies actually suggested benefit of short course of reducing regimen of oral steroids with antibiotics. Of course, this is recommended only to be used judiciously when there are no other options. Saline irrigations, excellent safety profile, highly encouraged. Few trials have also shown efficacy. Adenoidectomy and FES, both are effective. Both have shown good results. Of course, they are advised only when kids are having refractory benefit, no benefit to medical therapy. And new hot topic nowadays is biologics, new drugs coming up. There is no much evidence as far as I'm aware for pediatric age group, but the biologics when to be used in chronic rhinosinusitis with nasal polyposis, there are specific set criteria given by Eurofia guidelines, again a group of experts from this EPOS group. Based on the criteria, they have given the guidelines. Okay, if a patient has 3 of these criteria with history of surgery, you can consider biologics. The problem with biologics is the cost effectiveness. There's a one recent study which put up actually how much costly it is to go for dupilumab when you compare with endoscopic sinus surgery. It's actually surgeries are almost 1/10 of the cost of the dupilumab, which is a biologic used to treat nasal polyposis in chronic rhinosinusitis. Of course, over the time, if the biologics become cheaper, then probably they would be the best treatment available. When we talk about one airway, one drug would be the ideal choice. OSA and asthma, prevalence of OSA as such in asthmatics is very high. In pediatric age group, it's almost 30 to 60%. On the contrary, if you talk of asthma in OSA, it's equal to normal population. So is it obesity or rhinitis or nasal polyposis or steroids? Other factors contributing to OSA in asthma? Of course, there are many factors. Nothing one can be pinpointed. However, it has been proven many times that if we treat OSA, we definitely have benefit in asthma. On the contrary, that's not the end. The symptoms may come again, so treatment may be required further. OSA in pediatric age group mainly contributed by adenoids and tonsils. Adenotonsillectomy gives good results. Tonsils definitely never come back. Adenoids may not come back, but child may still get symptoms again. So we may have to think again whether adenoids have come back, or is it the chronic rhinosinusitis which is actually complicating the picture. So reevaluating the child actually gives us a better idea of what is happening. Flexible nasal endoscopy, it's a quick endoscopic procedure which can be done in clinic. We have a better idea what is happening. Is it the turbinates hypertrophy? It's the adenoids? Is it the something else which is actually contributing to severity of asthma? So inferior turbinate reduction, I've not mentioned yet, but that is also one of the surgical procedure which have been helpful in treating chronic nasal dysfunction, chronic nasal obstruction, which could contribute to OSA as such. So that has actually good results apart from adenotonsillectomy. Vocal cord dysfunction is a condition where we have paradoxical movements of cord. Cords which should be abducting are actually adducting during inspiration, and that complicates and sometimes may present as asthma. So we need laryngeal control therapy, which is provided primarily by speech pathologists, and that's the cornerstone in this cornerstone of treatment in this condition. Of course, psychotherapy and Botox injection may be required at times. Okay, so this condition is not severe, but it's actually very difficult to diagnose, and it is missed many times. Only by examination with the endoscopy, we can actually see the cord movements and get the diagnosis. So that's what I wanted to conclude from today. If we have a problem, we have a poor asthma control, I think we all know where we should look up to. Rule out other comorbid conditions. Most common, most important being allergic rhinitis. And many studies have shown that treating allergic rhinitis is helpful in asthma, and it may be there again and again, but it's definitely one important condition which needs medical management, which needs patient involvement in many ways. That's all from me today. Thank you very much for patiently listening to me. I would be happy to take the question.
Thank you, Dr. Love, for the extensive coverage of the ENT disorders, especially allergic rhinitis. It's associated with asthma. One airway, one disease. This is the latest concept. And as long as we are not controlling allergic rhinitis, we may not control the asthma also. So, any questions from the audience?
Alok, if I can ask you if you can hear me. As
Yes,
far
sir.
as general pediatrician point of view, in a case of mild to moderate adenoiditis with allergic rhinitis, you can take it. What should be the dose of steroid, nasal steroid, and how long would you give? And how do you think you can reassess again the child, whether the child is getting better or not?
For adenoiditis, yes, I prefer mometasone. We give it for a minimum of 6 weeks. I start with 3 weeks and see them again in 3 weeks, see the response, showing response, continue for 6 weeks and then reassess. And that would give you an idea like how, if not, you will have to think of changing the drug, maybe going to fluticasone. But mometasone is what I start first with. 2 sprays once a day. Initial 1 week, we can try twice a day, which is again debatable, but ultimately it's once a day regimen for entire 6 weeks. And after 6 weeks, no benefit, you can think of 12 weeks or think of other conditions, maybe get a further evaluation, maybe with endoscopy or a CT scan.
Any comment on laryngopharyngitis or what do you call laryngotracheobronchitis? I think Dr. Ramesh Srinivasan has asked a question. Laryngopharyngeal reflex.
As a cause of poor, yeah, laryngopharyngeal reflex, again, that's one thing I mentioned briefly, that is one of the cause which can contribute to, again, severity in asthma. Of course, that definitely needs treatment if there is, we'll come to know about it only when we get a proper evaluation for it. So I didn't focus treatment of that part, but yeah, that's one thing which everybody has to look at it. Laryngopharyngeal reflux, as well as aspirin exacerbated respiratory disease. Aspirin exacerbated disease also I did not cover because again, that is what we routinely know about it. Aspirin, if it is causing severity, we have to stop it. We have to slowly start giving tapered doses to treat it. So there's no much role of surgery in these two conditions.
Just one last question. What is refractory in cases of adenoids not responding to medication? How much time do we wait? It's a generalized question, I think. They're asking.
So that's what the recent guidelines which I presented from EPOS 22 guidelines says 6 weeks to 12 weeks is the time you can wait. Beyond 12 weeks, you are actually missing something. Probably the diagnosis is wrong, or probably you have to consider adenoidectomy, because that could lead to chronic rhinosinusitis or OSA or aggravate asthma. If only adenoids, no other symptoms, then I don't think child needs any treatment, because adenoids can be there in every child. If it is actually causing any of the symptoms, then actually we are treating them. If they are bigger in size, either they will cause OSA or they will cause nasal discharge, chronic rhinosinusitis, or something else.
Dr. Alok, this is Dr. Kedar. I have one question for you. What is your take on a combination of montelukast or montelukast with cetirizine when given along with nasal spray mometasone?
So problem with this topical combination of steroid and cetirizine is chronic usage of topical cetirizine will again have its dependency effects. That is what practical problem I face. So even if you start with the combination of steroid with cetirizine, you will have to slowly shift to only steroid combination without any combination, just plain steroid dose later. Otherwise, the dependency starts showing up, and once you stop this combination drug, you start seeing symptoms again.
Okay, thank you, Alok. I think that's it. I think we can stop questions here. We can go with the next speaker. Sir Sugnakar, sir, you can take over, sir.
Thank you.
Thank you, Dr. Alok,
Thank you, sir,
for the nice coverage. And I welcome Dr. Arif Ahmed, who is the pioneer of allergy in Twin Cities. So he has sensitized all the Twin Cities pediatricians way back for 15 years. 15, if I am right, 15 years or 20 years, 20 years ago, when he has started the first pediatric allergic clinic in the Red Hills area. Welcome, Dr. Arif, sir. Please proceed.
Thank you, Dr. Sugnakar, and I want to thank you from the bottom of my heart, Dr. Arjun and Dr. Suman, for giving me this opportunity to speak on allergy. To be very honest, this is the first time I'm doing a webinar for Twin Cities, although I've had the opportunity of doing webinars all over the country, including the prestigious MVCon in Mumbai. But to do at home is something of a great honor and a prestige, and there's nothing like doing a webinar in your own house. So the topic I've been speaking on today is routine bowling, different strokes. And why I took this topic, because this is the season of cricket and T20, or what you call as instant cricket. And what you see on the screen is this is, everybody is well aware, this is Dilshan, who was the first one to invent this famous scoop shot for a Yorker. And then we had this, here you have Dhoni, who is very well known for this helicopter shot. But it was actually first invented and practiced by Azharuddin from Hyderabad. So why I'm trying to talk about the different shots is that till now, for a routine bowling which was going on, then there's to be a standard stroke which used to be made. But then these players came up and they approached the same bowling, the standard bowling, in a different approach, because ultimately what they had to do was to score runs. So what we say was there was a paradigm shift in the batting to the normal routine bowling which was going on for years, and ultimately it brought results. So taking it back to our practice, what we see, what I'll be going through is the standard cases which you see in your practice and day in and day out. And then you have the standard approach every time. And these patients are passed on from one doctor to another doctor. So I would try to make you look at these same cases from a different perspective. Okay, so let's start with the first case scenario. So this is Zaid, a 2.5-year-old male and NRI from Australia, brought to my clinic, and he was brought to my clinic as a pediatrician, not as an allergist, for the complaint of a constant cold. Okay, this is a very standard child coming to every clinic. Just doctor, bar usko sardi rehti hai. What I noticed also that the child was not interacting well. And when we examined, there was no significant finding. So the question is, what has been, I will not like to go through as to what has been happening to this child in every standard clinic. But the question is to you as to what further would you do? So we took a detailed history, and I found out that the child was suspected to have autism by a GP because he was not interacting well. Speech was delayed for a 2-year-old, just 3 to 4 words. But more important, there was snoring was present, no other associated symptoms, not much active with peers, and very restless at all times. So, I mean, it could be just a cold which is causing this problem with a behavioral problem, could have been autism. But then the question arises is, what test would you do? So the most important test is an otoscope, which all you should try in a practice. And we tried an otoscope, but not appreciate the movement of the eardrum because the child was very restless. So in such a scenario, what you should do and what we did was doing a tympanometry. Okay, and the tympanometry, it just costs about 300 rupees in the city of Hyderabad. It's widely available, and it showed bilateral middle ear effusion. We also, because of the snoring, we also did an X-ray which showed moderate enlargement of adenoids. So based on this, our diagnosis was bilateral middle ear effusion with adenoidal enlargement. So a child who had a constant cold, going into details, we made this final diagnosis of bilateral middle ear effusion with adenoidal enlargement. And mind you, he was not having fever with each of this constant cold. So what would be a diagnosis and how would you treat? So what we did was we gave a 2-week course of intranasal mometasone plus a montelukast and plus an antibiotic. And then what we did after that was we repeated the tympanometry, which showed no effusion. And after this, the child was very interactive and the restlessness had come down. So the next, so the child, constant cold, going around to different doctors, we have made a diagnosis by looking and taking a detailed history of bilateral middle ear enlargement, middle ear effusion with adenoidal enlargement, treated with intranasal steroid course, and has caused an improvement. But we went further than this. Okay, what we did was we did blood test studies. Okay, now for dust mites. Why should we always do these studies? In any child who has middle ear effusion or adenoidal enlargement? That would be the common question which would be asked. But why in this child we did this test? Because each one of this, but if you do it by the immunocap or the FBI method, it really costs. Each of these tests, okay, now we have cost 1,000 rupees. We did it because we took a detailed history and we found that this child staying in Australia, the home was fully loaded. I mean, there were the pets, I mean, not the pets, sorry, there were carpets and all that which would cause exposure to dust mites. So the DFARNA was 68.70 and the terinosis was 52. Both were very high. So based on this, what we did further was that we did a hearing test, the year which should be done and which is normal. So the treatment was the good environmental aeroallergen control, and that's what we followed in this child, good environmental aeroallergen control. And what is this environmental aeroallergen control? Is mainly dust mite control, and there are standard steps and measures to bring about dust mite control. But for that, it is very essential that if you should first identify the aeroallergens. The next question is, now this child has improved with mometasone and montelukast. So what should be your further line of approach? I mean, the previous our ENT colleague has somewhat answered this question. So whether you should give mometasone or mometasone plus montelukast or only montelukast only. So it is a matter of, at this moment, we gave mometasone, the child responded. What I would do is continue with montelukast, but if the symptoms are recurring in spite of good environmental control, then we have to switch back to mometasone in this child. A ENT opinion is required is a matter of difference. I wouldn't go for an ENT opinion because as an allergist, I'm confident, I feel this is nothing but allergic rhinitis with which is causing adenoidal enlargement, and we just continue with good environmental control, education of the patient, very, 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 very important. Our education about what the condition is, what the likely impact is going to be, and teaching them about good environmental control. T-adenectomy. Now, whether you should do adenectomy because of the snoring, no, it's not required because there's something like a medical adenectomy. You give a 6 weeks course of mometasone and the adenoids just shrink, and that's what happened in this case. The adenoids just shrunk and the snoring had disappeared with just a 2-week course of mometasone. But you can go up to as high as 6 weeks to 8 weeks. But at the end of the day is this child who had some interactive problem, you should always think of the possibility of an autistic spectrum disorder should be kept in the mind and follow up for that. Next, the second case is a 2-month-old boy, exclusively breastfed, given supplemental bottle of cow's milk. 4 hours later, he developed profuse vomiting and diarrhea. There was, along with the diarrhea, the lethargy and sepsis-like picture taken to the ER, which diagnosis should be considered. Now, this is a very standard case. And what we have been doing till now, with the stroke that we have been making is we have been thinking of sepsis, yes, because there's a sepsis-like picture. It occurs with an acute episode. Interception, yes, you introduce the formula. You think of interception. You're thinking of volvulus also, you will be thinking about. But now what you have to also start thinking at this moment is, because besides these 3 conditions, you should think of a new condition called FIPES, acute food protein induced enterocolitis. And what is FIPES? I'll get into it subsequently. It's nothing but is a non-IgE mediated food allergy disorders among other non-IgE mediated food allergy disorders such as food protein induced enteropathy, food protein induced proctitis and proctocolitis, and your eosinophilic esophagitis, which is present mainly in adults. So, and I'll try to explain this case with this 5 with another case. We had this child, 6-month-old baby Rahul. Okay, he was previously well, breastfed. Then he vomited 3 hours after the first formula feed, and there were no other symptoms. It settled spontaneously by the next day. We thought of gastroenteritis, and we continued the breastfeeding. Okay, so a child at 6 months vomiting with the first formula feed. Okay, then we tried again with the bottle 1 month later. After 2 hours, there was profuse vomiting, and immediately the baby became pale, he became floppy, he was shocked, there was no rash, there was a sepsis-like picture, he was taken to ER. So the question is, what diagnosis should be considered? Would you consider sepsis in this? No, I would not consider sepsis in this because it's a repeat episode after with a gap of 1 month. Would you think of volvulus? That also would not recur. Food poisoning and GRD? No. So what do we think of volvulus? Somebody would ask me, why should we not think of food milk allergy? Yes, that's a good question that you can think of milk allergy. But then there's one thing, there was no rash, and Ig-mediated milk allergy, cow's milk protein allergy, would cause a rash. But remember, in a case of shock, you may not see the rash. So, but the most important thing is an Ig-mediated milk allergy would respond to a IM adrenaline. This child did not show any response to IM adrenaline. So the question of milk cow's milk allergy or Ig-mediated allergy is out. And this child improved with IV fluids, and that is the basis of treatment for pipes, just giving IV fluids. Subsequently, later, we did the skin prick test and the IgE to milk, and both were negative. So, pipes is a condition which shows symptoms like cow's milk allergy without any rash, okay, with leading to shock, but will not lead to anaphylaxis, and in which the IgE test or the skin prick test will come negative because it is a non-Ig mediated food protein induced enterocolitis. Now the case number 4. A mother gets a 5-year-old son with repeated nasal congestion and cough. She says that this cold is aggravated banana fruit. And this is a very common thing. I mean, this child, and what we think is, well, it's a banana. Well, and we presume and we say this is banana allergy. Now here I want to tell you is that why, before I tell you why banana causes this problem, I will like to, what we do is we do a prick to prick test. We prick the banana and then prick the skin, and we show that there is no response to the banana. There is no reaction. And we also did the Ig blood test, and that was negative. Now, important thing, why you should not think, because if there's a banana allergy, there would be rash, there will be itching, there will be swelling, and there will be also gastrointestinal symptoms. These are the important things which you should look for if there is banana allergy: rash, itching, swelling, and GI symptoms. And this child had none of these. So then the whole question arises is, why is this child having these symptoms to banana? It is because of the enzyme in the banana which inhibits the breakdown, okay, now we have of histamine, and the histamine in the banana will cause act as a local irritant. So it's the same, it is banana is taken in warm milk, warm water, or with the chili powders and pepper and all, they may not cause the local symptoms. So that's a very important thing. You have to, before you label them as banana, label it as blindly as allergy and dissuade the child from eating bananas, make sure that that there is no banana allergy, and do not, because almost 60 to 70% of the patients who is having upper respiratory symptoms will have may show adverse effects to banana. And this is the last case. We had a 14-year-old boy with history of these in childhood, developed urticated rash and swelling of lips on ordering Hyderabadi biryani from a takeaway. He responded to emergency treatment in ER, history of similar but mild episodes in past on takeaway biryani, no such episodes on home cooked biryani. So what we do normally is, okay, you had biryani, you had the biryani, you tell me what are the contents of the biryani, and we check the different, the skin prick test for the different contents of the biryani. And we did that and it was all negative. So the question is, why was this child showing these reactions? And look at the important thing. Homemade biryani, no reaction. Well, outside biryani, yes, there was a reaction. That is what I want to sensitize the pediatricians about. That a big cause of this allergic reactions for which we have no testing done are the colors, okay? The food colorants. These are the food colorants. Tartrazine, which causes urticaria, sunset yellow, carmine, sulfites in drugs, and benzoates and nitrates. And these, now most of these foods outside, okay, especially in marriages and all, whether the sweets and all, they'll be containing colorants, and these colorants can cause reaction. So please, so any child taking any getting this urticaria type of rashes by eating food outside, see to it that they avoid foods with colorants. With these things, I hope I am able to bring about a different perspective in the standard and routine cases which you see in your clinic. Okay, and for further reading, I would advise you to go through my book, Winning Over Allergies, Myths and Facts, brought about by Hay House Publications. It's a very simple book, which is for both doctors as well as patients. It is available on Amazon, and you can buy it from Amazon. With these words, I thank you, and I thank Twin Cities for giving me this opportunity. Over to you, Sugnakar sir.
Thank you, sir, for nicely covering different aspects of the allergies. Any questions from the audience, please?
Okay, that's good.
One observation, Dr. Arif, your presentation is quite lucid as always been. And let me remind you.
Quite or very lucid? Is it quite or very lucid?
And again, let me remind you, IAPTCB is committed to encourage the local talent and also not only give ample opportunities for wonderful talent that we have at home. So son of the soil, and it was a pleasure privilege to let you deliver the oration also, annual Pedicon oration. Just recently.
I consider honor myself to be in Twin Cities.
So great to have you and others also. Dr. Sugnakar, go ahead. Sorry.
As there are no more questions, I will hand over the session to Suman.
Yeah. Thank you, sir, for the session. I would just ask one final question to Arif, sir. First thing is, as of now, are you doing immunotherapy? Because that's a challenge now. Once you identify a child with food allergies, avoidance wouldn't be the only solution. Identification of it and avoidance wouldn't be a solution. Are you starting an immunotherapy? Because most of our allergists are not doing it. Only few of us are doing it. If you are doing it, we know where to refer.
Okay. Thank you, Suman. The only validated food, as far as immunotherapy, it has shown very good results for aeroallergens. And in aeroallergens, mainly for dust mites and for pollens. It is not validated for fungus, for cat, dog, and cockroaches. For that, avoidance is the best measure. That's the first thing. So dust mites and pollen, that's it. Most common is dust mites. So you should go only for dust mites because it's very difficult to avoid dust mites. Next comes to food. The only thing which is validated is for peanut. Okay, and if it is life-threatening, then you should go for it. As far as myself I am concerned, I do only immunotherapy for aeroallergens and not for any of the food allergens, because I feel unless it is, I personally don't feel that to go for any of these for immunotherapy, strict avoidance would be a better measure, because we do not have good immunotherapy for food allergens available in a country. It is available with these laboratories in Bombay and Delhi, but they are not standardized. You can make a try, but I'm not confident doing it with the ones available in our country for food allergens.
Sir, I accept it, sir, because immunotherapy is something which is not applicable to food allergy right now. We can think about it, and we can treat only one allergen. We can't treat multiple allergens as far as immunotherapy is concerned. Thank you for your time, and I like your hairstyle and your beard, sir. They didn't see your ponytail actually. It's quite stylish.
When you meet, we can. Thanks so much.
We'll go and get on with the next session. It was
Sir, a session. I have a question for Dr. Arif.
Yeah, please. Yeah, go ahead.
Yeah, Dr. Arif, I have a question for you. What is your experience and your take on food desensitization therapy?
I think that Suman just asked about that, and I would not advise desensitization or immunotherapy. They both are the same for food allergy. Avoidance is the strict. A strict avoidance is the only answer. That's it.
And the good thing is food allergy, the patients always outgrow it. That is something which we can motivate the patients. What we need to know is it intolerance or is it allergy? That's a difficult aspect. Which
I mean, Suman, milk allergy is the commonest thing in our setup, and they usually outgrow milk allergy. Peanut allergy, they do not outgrow peanut allergy or tree nut allergy. But fortunately, in the Indian scenario, peanut allergy is not common. We see this mainly in the Western world. In Indian children born and brought up, they will be very common. And there are various reasons which I've explained in my book why peanut allergy is not common in the Indian scenario, because of the way peanuts are cooked in the West. They have roasted peanuts. In the Indian setup, we have boiled peanuts. So there's various reasons. Okay, so why we don't have it. Okay, over to you.
Yeah, thank you, sir. When you cook, usually the protein gets degenerated and the allergic capacity of that, protein usually goes down. Thank you, sir, for the update. We'll go ahead with the next session. I think we have gone with asthma and difficult cases of asthma. And with this, I welcome our next, the chairpersons, Dr. Srilata and Dr. NL Sridhar, to introduce the speakers right who will be taking over for the next session. So welcome Dr. NL Sridhar and Dr. Srilata, please.
Yeah, thank you so much, Suman. This is a nice program what IAPTCB had arranged. And welcome Kedar and Spurti and Madhavi. And today's first topic is Beyond Basics, Urticaria in Children by Dr. Kedar. And Kedar is my close friend, and we had a very good relation. We worked in one hospital, and he's from Dr. Kedar. Suman, biodata of the Kedar. Kedar, able to hear?
Yes, sir. I'm there.
Yeah, you please. Your presentation is first. Please, biodata. You please focus on that. Please display that.
Okay. Shall I start it?
Yeah. First slide. Your slide. First introduction slide of.
Yeah, I'll start.
Please.
So I think I'm audible to everyone.
Let me introduce. Your slide should be there. That's the main thing. Your biodata should be there. Yeah, Dr. Kedar, can you focus your biodata on as a first slide?
Yes, I've already made my first slide.
Yeah, next. So, Dr. Vamshidhar Kedar is the medical director and lead consultant pediatrician of the Lotus Hospitals, and he's schooling from Hyderabad and MBBS from CMS Bharatpur. He secured university ranks in physiology, general surgery, and ops and gynes. And really, that shows your interest in ops and gynes also. So, and second thing, he had served Mumbai pediatrics training in KEM Mumbai, which is one of the premier teaching institutions in India. He has served Mumbai Municipal Corporation as a special registrar in pediatrics in Rajiv Gandhi Medical College and Teaching Hospital. And later he worked as a critical care specialist in Kanchikomakoti Child Trust Hospital in Chennai. And further, he worked in Lotus Children's Hospital for 3 years in pediatric critical care and neonatal care and pediatric cardiac care units also. He completed diploma in DNB in pediatrics during this period only. And he was a consultant pediatrician and intensivist in our hospital, Neo BBC Children's Hospital. And later he became the consultant and partner in, and he had experience in worked in Innova Hospital also. Became a consultant and pediatric intensivist and allergy specialist. A lot of things are there towards his career. And he is now medical director of the Lotus Children's Hospital. And he had a director of Lotus Hospital in Vizag also. So all the best, Kedar. You can take over now.
Thank you, Dr. Sridhar. It was a very big to tell about me. Now, coming to the topic that I'm supposed to be talking today, at the outset, I would like to thank IAPTCB for giving me this opportunity to share my views on urticaria. Now, this is something that I'm giving a key to you. Key is an iron object where you can put it under your pillow, you can scratch your itch, or you can throw it away. You can do either with a key. Most important thing a key does is to put it in a lock, to open the lock. and you can't put it in any lock of your choice. You have to put it only in one specific lock to open the key. So the key I'm going to today is the discussion of types. And actually going slightly beyond the basics of discussion in this scenarios and what you might get carried away in some scenarios as well. Now, the outline of my today's talk, I would like to complete the next 20 minutes, is to discuss about the review of allergic mechanism, what is urticaria, to be described on classification, causes, and treatment, angioedema, pain, to be discussed as classification, causes, and treatment, and lastly, approach to the urticaria angioedema complex. Now, the review of allergic mechanism, as we all know, allergic mechanism is a very common phenomenon when the initial allergen exposure, the allergen attaches to the B cells and transforms them to plasma cells, and this IgG antibodies which are released are initially bound to the mast cells. So these antigen antibody complexes are formed, and a recontact with the allergen causes the antigen antibody to the mast cells and release histamine, and this histamine causes the various symptoms, and this is responsible for the symptoms. As we all know, there are two types of mechanisms inside our body. One is the Th1 pathway and the Th2 pathway. Th1 is primarily responsible for infections, whereas Th2 is primarily responsible for allergies. There is always a very delicate balance of the allergy with a normal condition. Where an allergic person, Th2 weighs more than in cells. Whereas healthy person, the immune Th1 and Th2 is maintained by the T regulator cells. They cause not much of symptoms pertaining to allergy. Coming to the area, we had a very interesting case. 8-year-old Ruby, who presented this way. On review of the history, the child was severely presented acute exacerbation of asthma, and on history, the child had written urticaria for the past 4 months. The child needed admission, and the child was.
Kedar, sorry to interrupt. Your voice is not clear. Can you please check your audio, because there's a lot of disturbance? Can you please check it up? Then I'll.
Suman,
yeah,
can we go to second session, because if it is if he comes back, Kedar.
I think he can come back straight away.
Yeah, Kedar. Unmute yourself, Kedar. Unmute yourself. Kedar, unmute. Yeah, yeah. Please. Yeah. Now it's, I think you got a good signal. Yeah.
Now, am I audible, please?
Yeah, you can start sharing your screen. Kedar, you can start sharing your screen.
Am I audible now?
Yeah, you are audible. Kedar, you can share the screen.
Hope I'm audible now to all.
Yeah, you are audible. Share the screen now.
Yes. There has been some problem in the internet, so I'm just sharing my screen.
Yeah, please go ahead.
Sorry for the technical aspect. So we had this 8-year-old Ruby who came with a severe urticarial rash. On review of the history, the child was severe asthmatic, presented with acute exacerbation with recurrent urticaria, which was lasting for nearly past 4 months. The child needed admission too. The child was managed initially accordingly. Symptomatic and diagnostics were also sent. The child was acutely treated with IV steroids. The child became better. And the child was discharged on day 2 with budesonide MDI with spacer, as and when required levosalbutamol as an emergency medication, oral cetirizine, and oral montelukast. The child came back on day 20 with acute exacerbation again with severe urticaria. The first spirometric evaluation was done now. It was measured by a handheld spirometer and it was less than 65%. FEV1 was less than 65%. Chronic spontaneous urticaria was diagnosed based on the EAACI UAS score of 35. I'll discuss UAS score in the further slides. After acute stabilization, the child was commenced on formoterol plus budesonide, oral cetirizine, oral montelukast, and oral cetirizine was gradually discontinued after 15 days. We have sent immunocap because I was unable to do the skin prick test because of the extensive nature of urticaria. It was positive to house dust mite. And all of the investigations were sent. Even though it was non-specific, vitamin D and serum IgE were also sent, and IgE was more than 10,000. What is this urticaria activity scoring of 7? The 7 indicates a weekly score over 7 days. The urticaria activity score for 7 days with a total of 42 and minimum being 0 and maximum of 42. It takes into consideration the wheals and the itch, where no wheel and itch gives a score of 0 and severe wheel will give a score of 3, with severe itching gives a score of 3. Usually a score of 6 may be evaluated as well controlled, 7 to 15 as mild, and 16 to 27 as moderate, and 28 to 42 as severe urticaria. For this particular patient, the score was around 35. What next? So the only thing that got into my mind is whether to go in for immunotherapy or whether to go in for any alternative therapy. The only thing that came up to my mind then is to try omalizumab, because as per the criteria given for urticaria, the next level of treatment we can give omalizumab, which is recommended and widely used as an add-on treatment option in severe allergic asthma in children, according to the GINA guidelines as well as urticaria guidelines will be shown in the next slides. We recommend using omalizumab. 75 milligram of omalizumab was given subcutaneously monthly with all institutional precautions given. And as per the previous treatment protocol, montelukast and budesonide formoterol were gradually tapered and stopped at 24 weeks, the 6 months of omalizumab therapy. After 3 months of therapy, the urticaria activity score was reduced by 50% and it came down to 14. And at 3 months, it was reduced to almost 0. And after 1 year, the child didn't have any further symptoms of urticaria, which confirms the resolution of the disease. After 6 months of therapy, the child also showed an improvement in her symptoms in agreement with the global spirometric values. FEV1 was more than 95%. And moreover, the patient did not manifest any adverse effects due to omalizumab therapy. At 6 months, I checked the total IgE, which was 2,800, and at 12 months, the IgE was 368. Coming to the short discussion about urticaria, it affects 20% of population and it occurs across all age spectrums. And sometimes it is possible to identify the trigger, which can be food, drug, insect stings, etc. And more than 2/3 are self-limiting. The characteristics are mostly pruritic, which are seen at nights, which are erythematous. They often exhibit central pallor and it blanches on pressure. They are usually oval, round, irregular shapes or plaques, and the plaques move to different locations over minutes. They show a movement across the body and usually last less than 24 hours. It leaves no residual marks other than the scratch marks. Coming to the pathophysiology, as everyone are aware, it's a reaction mediated by the activated mast cells and basophils in superficial dermis. When activated, the mast cells release histamine, causing itching, and the vasodilators cause severe swelling. The same process is seen in angioedema, but in the deeper layers of the skin and subcutaneous tissues. Coming to the classification of urticaria, it's usually acute versus chronic. In acute episodes, usually last less than 6 weeks and more likely to have an identifiable trigger, whereas the chronic episodes last more than 6 weeks and less likely to have an identifiable trigger. Common cases of acute urticaria that we come across are either foods or food products, most likely milk, egg, peanuts, wheat and soy in kids, and tree nuts, peanuts, and shellfish in adults. Sometimes the food colors, as explained by Dr. Arif, can also cause acute urticaria. Contact with animal food, animal saliva, certain vegetables and detergents also can have urticaria. Viral and bacterial infections are well known, especially in children, to cause urticaria. And parasitic infestations also manifest with urticaria. Certain medications and stinging insects, the stinging insects especially cause more angioedema than urticaria. Latex products are well known to cause urticaria. Also, foods and drugs like narcotics, muscle relaxants, vancomycin, NSAIDs, and ACE inhibitors. These are less likely causes, but definitely are causative. Physical stimuli are very, I don't know, perhaps in the recent past, approximately 3 to 4 months, I have seen a slight increase in this particular phenomenon where the cold temperature, exposure to sunlight, and pressure also are causing acute urticaria. But they are mentioned under the category of uncommon causes. But of late, I have seen a slight increase in the prevalence of cold and sunlight exposed causing acute urticaria. Serum sickness reactions, as we all know, and progesterone associated, which is less likely to be seen in children. Causes of chronic urticaria are usually autoimmune in nature, probably caused by underlying factors like SLE, JRA, thyroiditis, etc. And chronic infections like mycoplasma, tuberculosis, H. pylori. Stress can cause chronic urticaria. Urticarial vasculitis, a very well-known phenomenon. Malignancy and pseudoallergic vasculitis, which are caused by preservatives, sweeteners, and occasionally wine, alcohol. Luckily, today we have the virtual meet, so this question doesn't exist for many. Coming to the diagnosis, the most important key is the history. History is the most important factor where we can pinpoint to the root cause of the urticaria. Has the child had urticaria before, unusual exposures, food consumption prior to episode, and if disappeared, the pictures of the lesions may sometimes give a very important clue to the diagnosis. A detailed physical examination may sometimes provide a clue, and lab testing, all the routines, allergy testing, if any specific trigger can be amplified, or even the immunocap is of a great value in diagnosing the chronic urticaria. In chronic urticaria, investigations based on the other history is also should be considered. Coming to the treatment aspects, broadly there are two categories, the H1 antihistamines and the H2 antihistamines. In H1 antihistamine, the first generation are more sedating and require more frequent dosing, whereas the second generation can be given at a higher dose than standard dose to get the desired result, and sometimes be sedating at higher doses. But usually the most common choice are always a second generation H1 antihistamines. H2 antihistamines like ranitidine, cimetidine data are not particularly supportive, and pregnant and lactating may use loratadine and cetirizine also. The reason why I put this point is sometimes we come across adults also sharing their experiences, and being an allergist, we can't simply concentrate on the child, and sometimes, and especially these days, I'm getting the parents of the children who are having a recall of their childhood symptoms and coming for me for the treatment of the same. Steroids, of course, are very important in the treatment of urticaria. Prednisolone, either given oral or intravenous, and usually dose can sometimes be incremented for the desired effect. Initially given for 5 to 7 days and then tapering. For admitted patient, if you're expecting a quick result, methylprednisolone can sometimes be used. Of late, deflazacort has been shown to be promising in chronic urticaria, less than 2 years. Again, no data. More than 2 years, 1 mg per kg, not exceeding 12 mg once a day for 7 days, and gradually giving it alternate for 7 doses can be used. Coming to the approach to management, as I have described earlier, there are 4 steps of approach to management. The first step being monotherapy, second step, advancement of therapy, step 3 is advancement and adding an additional drug like omalizumab. Now, second generation antihistamine, if adequate control for 2 to 4 weeks, increase the dose of second generation antihistamine up to 4 times. Again, if you find any inadequate control, you can add omalizumab and then switch over to cyclosporine if the treatment options are not satisfactory. Coming to the angioedema, this was a very interesting case which I accidentally happened to stumble upon. I was not directly involved, or I was not even called to see this patient. A 29-year-old Evelyn, this particular woman came with lightheadedness, severe abdominal pain, intractable nausea and vomiting since 12 hours. Basically, when they came to the emergency, a junior consultant in the Department of Gynecology has actually attended this particular patient. There were history of previous episodes of abdominal pain, swelling of her hands, not associated with any urticaria. She was on oral contraceptive pills prescribed elsewhere since 1 month, and the child had similar episodes in her father too. And in childhood also, the child had abdominal cramps. She's afebrile. She was in shock with a BP of 75/40 and a heart rate of 120 with diffuse abdominal tenderness, guarding and rebound tenderness. How should this be evaluated? I was not there. So the child, the patient was managed according to the ALS protocol with the help of an adult physician who was called in to take care of the patient. And I was just happened to pass by the emergency. I saw this, got interested, got curious, and have discussed with a junior consultant in gynecology. She explained me the whole history. Then I was taken aback and insisted on investigation C3, C4, and C1 esterase inhibitor antigen. To my surprise, there was low level of C4 and normal C1 esterase inhibitor antigen, normal antigenic C1 and C3 too. Measurement of C4 levels is a very cost-effective screening tool in hereditary angioedema. Now, I'm guessing in the back of my mind, this can be hereditary angioedema. The C4 levels can be normal in between the attacks. Now, to summarize, I was just recapturing all these things in the back of my mind. There was no urticaria, angioedema of the face, gut, and peripheries, where the woman has manifested with probably angioedema of the gut. This may mimic acute abdomen. Laryngeal attacks can be fatal, so I was very watchful for her saturations and other things. The patient came in shock. Family history may be present, may be absent, but in this case, the father had similar episodes. Blood levels were sent. Here, the C4 is normal, and low level of C4 has been documented. So I knew that it is hereditary angioedema. I was not able to picture exactly where to fit in. I knew that antihistamines and steroids and even the epinephrine wouldn't help in this child. I tried my level best, and by luck, I was able to procure Berinert. So this is a C1 esterase inhibitor concentrate, Berinert. I gave 800 units of them, slow intravenous infusion over the next 1 hour. And the woman, there was a fantastic improvement in the clinical symptoms. The symptoms resolved within the next 2 to 3 hours. And I was ready to give them the guidelines, if any laryngeal symptoms, to admit in the ICU and take further care. We may put the woman on Cinryze also, but I was unable to get it. I'll explain all these medications in the future slides, how to approach angioedema. And some patients can have icatibant home therapy also. This is something new for me. This is very unique for me. Now, what are the characteristics of angioedema? Similar process to urticaria. This occurs deeper in the subcutaneous tissues. Swelling due to extravasation of inflammatory fluid into the tissues is seen, and this is typically seen in areas with little connective tissues like lips, face, hands, feet, and genitalia. This can occur on bowel wall as a colic abdominal pain. Rapid in onset, often asymmetric in distribution, and often sometimes on the non-gravity dependent areas. This can be associated as a part of urticaria angioedema anaphylaxis complex. This can be life-threatening if associated with the airway compromise. Classification, how do we classify this? There are two groups broadly, mast cell related and bradykinin induced. Mast cell related can begin in minutes of exposure to trigger, like especially to food drugs. This occurs concomitantly with urticaria, usually resolves within a short time, 24 to 48 hours. Bradykinin induced develops more gradually, often takes longer to resolve. It takes around 2 to 4 days. And the classical example we can give is the ACE inhibitor induced. What are the syndromes that are associated with acute angioedema? Idiopathic or recurrent angioedema, allergic IgE mediated angioedema, medication induced. The most important thing that we often come across, but sometimes we miss it, is hereditary angioedema. There are 3 types. Type 1 is the C1 inhibitor protein deficiency, the type 2 with the protein being dysfunctional, and type 3, or it is coagulation factor 12 gene mutation. Acquired angioedema is again subdivided as type 1 and type 2, type 1 being associated with the lymphoproliferative disease and type 2 an autoimmune in nature. Episodic angioedema with eosinophilia is also seen, and the thyroid autoimmune disease associated with angioedema. To diagnose, the certain cues are very important. Were there any allergic symptoms, new exposures, immediate events after the exposure, any family members with similar episodes? This might give a very valuable cue. Coming to the epidemiology, when we go to this chart, 75% or nearly 80% of them, they have only 4 categories. The first and the foremost, most important thing is the unknown category. The second thing is the C1 esterase inhibitor, which can be either hereditary or acquired. 11% usually present with the other categories, and a specific factor can always be identifiable in these things. The common triggers being menstruation, infection, stress, medications, and even trauma. This hereditary angioedema usually presents in second decade of life, may be seen in children or in early 30s also. And edema can be present in different organs and can alter the presentation, like in tongue, in GIT, in extremities. In tongue especially, I would like to focus that it may cause a fatal obstruction. This attacks usually last for 2 to 5 days. How to approach to the management? Basically the diagnostics. The initial step is the diagnostics. The 4 things that are of valuable is the antigenic C1 inhibitor, functional C1 inhibitor antigen, the C4 and the C1q. And this patient about whom I have discussed falls into this category of type 2 based upon the investigation. Coming to the management, which I was discussing earlier, we have 3 categories of treatment over here. The purified C1 esterase inhibitor concentrates. The mechanism of action is by decreasing the bradykinin production, the bradykinin B2 receptor antagonist, and the fibrinolysis inhibitor. Berinert is one of the main line medication which can be given as 20 units per kg, which can be used in acute management. Maximum dosage is 1000 units, given by slow IV infusion over 1 hour. Usually the half-life of this drug is 22 hours and time to peak is usually 4 hours. Coming to Cinryze, it's 1000 units per patient dose, used for prophylaxis, given as slow IV infusion, and the T-half is usually 56 hours and time to peak is 4 hours. Icatibant can be given as a home therapy, as 30 milligrams subcutaneously, 6th hourly for 3 doses. And a very good medication, a fibrinolytic inhibitor, is tranexamic acid given oral or IV at 25 mg per kg per dose, 4th hourly up to a maximum of 75 mg per kg per day. Now coming to the approach to urticaria angioedema complex. This is one thing which is quite confusing to all of us as practitioners. Urticaria angioedema complex is either you have urticaria alone, urticaria with angioedema, or angioedema with or without urticaria. This is a complex phenomenon where we need to be acting fast and thinking fast, just like driving on a highway where we need to be speed and accurate and to avoid any dangers. This is all in the form of algorithms. You can easily go through it. So primarily angioedema without urticaria. It can either be acquired or hereditary. In acquired causes, it can be without any identifiable cause, with ACE inhibitor treatment, with C1 inhibitor deficiency, or the hereditary can be subtyped as C1 inhibitor deficiency with a normal C1 inhibitor. This can be genetic without any family history or with family history. Coming to the approach of angioedema with or without urticaria. Now, without urticaria, we have already seen that the main diagnosis depends upon C1 inhibitor activity. If it is less than 30 to 50%, either congenital or acquired. In congenital, we usually have C1 inhibitor concentration is the mainstay of treatment, which is hereditary angioedema type 1 or type 2. With a normal C1 inhibitor activity, it can be either congenital or acquired. With urticaria, if the urticaria is persisting, lasting less than 6 weeks, it can either be idiopathic, infection-associated, pseudo-allergenic, or allergenic. Chronic urticaria more than 6 weeks can be spontaneous, physical, or associated with autoimmune disorders. Recurrent angioedema without urticaria. Approach to management is usually to protect the airway, giving epinephrine, corticosteroids, antipruritic treatment, antihistamines, and LTRA. Especially for the hereditary aspect, epinephrine and corticosteroids play no role. All these are in the form of algorithms which can easily be downloaded from the net and seen for the approach. Most important thing is we need to identify the causative factor and try to remove the causative factor if it is identifiable, or go for the further investigations to quantify our data. Thanks for your patient listening.
Very good presentation, very enlightening things, and the 2 cases which you have taken is very interesting, and really the angioedema, how it makes us worry in the emergencies. Really, you had thrown light on that. Any questions from the audience? Please, you can type in the chat box. And Suman, can we go for the second session?
Yes.
Yeah, Srilata, you can.
Yeah,
please.
sir. Yeah. So we'll move on to the next session. Let me introduce the next speaker, Dr. Spurti. She's a consultant pediatric allergy and asthma at Rainbow Hospital. Dr. Spurti completed her pediatrics from Newark University and pediatric allergy fellow from Singapore. She also holds fellowship in medical genetics. She has special feathers in research field and she had various international publications on food allergies. So for the next 20 minutes, Dr. Spurti will be talking on the topic, the role of IgE in pediatric allergy. So over to you, Dr. Spurti.
Thank you, ma'am, for the kind words. Good evening, everybody, and I would like to thank the esteemed members of IAP Telangana for giving me this opportunity, and all the seniors present here and my colleagues. So today I would be talking about the role of IgE in pediatric allergy. Sorry, I'm not able to go to the next slide. So before understanding more about IgE, I would like to tell you about the important nomenclature. So what is atopy? All of us talk about atopy, right? So what is atopy? It's a genetic predilection to produce specific IgE following exposure to allergens. So what does that mean? In general, you can call it as an allergic family. So you can just say this person belongs to an allergic family, which exactly means that he has a family history of atopy. And next, the important term here is sensitization. So which is production of allergen-specific IgE. So what does that mean? So here, sensitization is demonstrated by skin prick testing or in vitro test for IgE to specific allergens, which we call it as immunocap here, which is available in India. So what we'll have to remember here is sensitization is not same as being allergic to that allergen, because individuals may produce IgE to allergens in a given substance, but do not develop symptoms upon exposure to that substance, which briefly would mean allergy on paper, meaning to say that it's documented on paper, but without any symptoms. So this is what is sensitization. So now what do we mean by allergy? So here, when a person has both allergen-specific IgE and also develops symptoms upon exposure to that allergen, so that is actually termed as true allergy. So which is again, basically it is demonstrated on paper as well as clinical symptoms. So having understood these terms here, I would like to go to the case scenarios, and Dr. Kedar has presented it very well. The cases were interesting, but here I've selected the very basic case scenarios that pediatricians would come across in their regular day-to-day practice. So a 3-year-old preschooler with recurrent episodes of runny nose seen by a pediatrician ordered total IgE. So I will leave this case scenario here. Let us ponder about it at the end of this session. So we'll go to this case scenario 2. This is also a quite common one. A 10-year-old boy with hives for the past 2 weeks, almost every day, came with a report of total IgE to me, and also he had reports of food panel and aeroallergen panel. So what do we do and how do we go about? So before even ordering the total IgE, or for that matter any test, what I would like to understand is, would food allergy be present for the first time in a 10-year-old child? So this gives rise to the question, when do food allergies usually present? So food allergies usually present for the first time at a very young age, for 1 year of age, or at the most 2 years of age, when the food is introduced for the first time in a child. So usually a 10-year-old may not present with the food allergy for the first time unless and until they've visited some exotic places and had some exotic fruits or some exotic nuts for the first time. So the age would go against food allergy, right? If it's a 10-year-old. And the next question would be, did parents notice any symptoms? And in this case, the symptoms are hives, right? Immediately after consuming any particular food. So when I say immediately, it's going to be either as the child is having the food or at the most within 1 hour. And most of the times the parents of a 10-year-old, right, who presents with this kind of a history, they'll come and tell us, doctor, maybe not immediately, but I remember that my child has had a chicken or some, mostly they say it's a non-veg food, a day prior and this happened. Or they even say a night prior to this episode, he's had chicken and he woke up in the morning having these rashes, right? Okay, if that is the case, then we'll go to the next question. Has he been eating that particular suspected food every day for the past 2 weeks? So because we are talking about hives for the past 2 weeks, almost every day, right? So when they say, yeah, chicken is the suspected food, then we'll have to ask them, every day were you giving chicken? Every single day? Because if it is just one time, he should have had the hives just that day, and then with antihistamine, it should have got better, right? But contrary to that, he's been having it for the past 2 weeks. So most of the times the parents would answer, no, it was just one time thing and we've never tried it again. So if no such clinical history has been given, do we need to blindly order a food allergy panel in this child with hives? I'm sure like all of us would agree that it would be no, right? All right, someone has already done it. So now we should understand which method is used. Is it RAST or immunocap? Or even before going to that, it's better we ask the parents, did the parents themselves look at some ads on the newspaper? You know, there are many newspaper ads, the front page itself saying that we do 100 or 200 allergens just for 2,000 or 3,000 rupees. So if that is the case scenario, please remember you can just throw it in the trash. Because if you look at immunocap, right, each single allergen would cost around like 1,500 and more. So if the child should get 200 allergens, as as the advertisement suggests, it should cost around 1 to 2 lakhs, right? So that itself would tell us that that's not the correct test. So now what it is it the RAST or the immunocap? RAST is an outdated technique which uses a radioisotope, which is still done in a few labs, and please do not go with it. You'll have to order immunocap, and thankfully, immunocap is being done in India for the past few years. Okay, all right. The next question is fine. Whoever has got it has some knowledge about the proper investigations, so they've got immunocap. All right. Now, how do we interpret the results of food allergy panel? Would the results be interpreted the same way for all foods? Here, the knowledge becomes very important because usually the labs give a report as saying that this is, they give levels here 1, 2, 3, 4, and they say if it's less than so and so, it's not allergy, it is more allergy, it is severe allergy, and all. But that would not make any sense because it is not generalized. Each food depending upon the age, the range is going to be very, very different. So for egg, it's going to be different. For for peanut, it might be different. So it's not the same. All right. Anyways, now we've got the immunocap report in our hand, and we know that it's done in a good lab. All right. So if your foods are reported positive, is it considered an allergy or the reason for hives in this child? So let's say in the report, they say the normal range, which means what they mean is no allergy if it's less than 0.35. And they report rice to be 2 and wheat as 6. Okay. So what would our advice be now? Now that we have a patient with hives, now that the report says if it's more than 0.35, it's positive, and rice and wheat is positive as per the lab report. All right. So what would our advice be? This is very, very important. So go back to the clinical history and please ask the parents, has he been eating rice and wheat products like, chapati, biscuits, breads, bun and all for the past 10 years without any problems? And I'm sure 99.99% sure, particularly in cases like this, the parents would tell us yes, then, yes, no problems. Then what would be the positive values for rice and wheat according to the lab reports mean? Because we know it's positive, right? So again, now coming to the terminology that I've told you about, it is just sensitization. Because it is just, we have a lab report with positive values, but no clinical features, and he's been having the same foods for the past 10 years. So it is sensitization as a doctor now, but would you be able to convince parents that it is just sensitization and not true allergy and not the reason for this hives in this 10-year-old? I think all of us would try, but then it's really, really difficult to convince parents that it is just sensitization and you should not avoid these foods in the diet. So I don't think so. Again, the question is, would the parents continue giving these foods or restrict them in the child's diet because the positive values are the ones that they've seen in the report, right? So here it all becomes, see, the reason, first of all, the food allergy, okay, I'll come to the next slide. So how best can we avoid this scenario? So by taking a proper clinical history and avoiding food allergy panel as a screening test when not indicated, especially when there is no temporal relation to foods, meaning like he's been having all the foods for a very long time and no symptoms all the while, right? So this should be avoided. And now I've also told you in this case scenario that a total IgE was also ordered. So what is the significance of ordering a total IgE in the child with hives? Again, as you guessed it right, it will not aid in diagnosis in any way. It's very important for all of us to understand that there is a huge overlap amongst IgE values in children with allergic and non-allergic disorders. For example, a child with an allergic disorder might have a low IgE levels, whereas a child with, with no allergic disorders can have a high IgE levels. And that's the reason it's very, very non-specific. So now coming to the case scenario 3, a 2-year-old child with hives and lip swelling within 10 to 15 minutes after drinking milk and milk products for the past 1.5 years. And so I've not included this in the history, but it's like mother has tried it first at 6 months of age when during Annaprasana and all, and noticed this hives and lip swelling. After a few months, granny has told them that Mirandaru Palapaina Perigaru Peru Pettandi ani. So they've given some curd, and the same thing happened at 9 months of age. And some aunt or uncle suggests that let's try cheese. So they have had several episodes with the same complaints of hives and lip swelling. And since then, mother has been trying to avoid it except for accidental exposures. And now, egg was introduced 2 months ago, noticed 2 to 3 episodes of vomitings within half an hour. So mother has been avoiding these both foods intentionally. Of course, there were some accidental exposures though. So now the mother is very anxious and she hasn't tried peanuts and tree nuts yet. It's a 2-year-old. So she wants to know exactly what foods the child is allergic to. So here again, any role of total IgE in this child? So my guess is what you would all think is no, right? There is no role of total IgE in this child because it is of no diagnostic value. The child might have a high total IgE or a low total IgE. It doesn't matter. Most likely she's having food allergy clinically. So the next step is do a SPT, which is the skin prick test to milk, egg, peanut, and all the available tree nuts. So we don't have to do for pecan, hazel. I mean, of course, we do have hazelnut chocolates, but most of the times it's the almond and the pistachio. Of course, the cashew too. So just do skin prick test to these allergens. So if positive, then for quantification and prognosis, order specific IgE, which I told you, right, immunocap to those positive foods. So now I've tried, so the second case was, I told you why it shouldn't be done. Specific IgE shouldn't be done. And the previous case, I've told you why it should be done, because the clinical history suggests so. So this is case scenario 4, 6-year-old girl with family history of atopy, diagnosed with severe infantile ectopic dermatitis at 1 year of age. So now she's come with a report of high total IgE. Mother is worried that food allergies might be the trigger. So now, what do we do here? So amongst the allergic disorders, when I say allergic disorders, what I mean is atopic dermatitis, allergic rhinitis, asthma, and all these things. Atopic dermatitis have a relatively higher level of total IgE. So irrespective of food allergies, most of the times, children with severe infantile atopic dermatitis would have a total IgE in general. So that's the reason it's not of any diagnostic value, right? So what do we do next? So you need to ask mother to maintain a food diary and ask her to note all the foods that would cause exacerbations of eczema. Because we should understand here that 1/3 of patients with severe atopic dermatitis may have food allergies. So yes, mother has noticed a few, in her food diary, she has noticed that a few foods would cause exacerbations. Okay. So for those particular foods, you can get a skin prick test done. But if it's extensive atopic dermatitis all over, there is no place to get a skin prick test done, then probably you could go for the specific IgE to only those particular foods. So there are many things which are, we have exceptions to all the cases that I've told you, but I don't really want to go into the exceptions. I just want to tell you what are the common things here. So, and interpret specific IgE to allergens in context of total IgE here, only in atopic dermatitis. So usually I told you total IgE is of no value, but in atopic dermatitis, if you suspect food allergies based on the food diary and all, and then if you think you should get a specific IgE done, then it would be good to also know what the total IgE is, if you're also getting the specific IgE done. Because what happens is in atopic dermatitis, the total IgE could be as high as 2000 to 3000 or also 4000. So you have a specific IgE of around maybe 40 or 50 and peanut of around 20 or something. Now, because it's at the back of your mind that the total IgE is high, right? So we should also think that probably the total IgE being so high is bringing up the specific IgE too. But it's also important to understand that it is not directly related. It's not proportional. Okay. So, but we don't know, probably he should have been 10 or something and it's bringing up to 80. We don't know, but in which ways we should consider it as allergy, but most likely it's not so severe. All right. So next, going to the next case scenario, this is the last one. So a 12-year-old boy with uncontrolled asthma on controllers, high dose inhaled corticosteroids, he's complained with the medication, but having 2 to 3 admissions per year for exacerbations. So he's come with a report of total IgE. So now we should understand what is the significance in this particular child. Okay. So role of total IgE in this scenario. In general, if a patient has mild to moderate asthma, which is very well controlled with a low to moderate dose of corticosteroids, there is no role of, there is no role of total IgE here. But this I would say as an exception because it is a 12-year-old poorly controlled asthma with multiple admissions per year and also maxed out on the total corticosteroids, right? So here it is important because this is the typical scenario where we could suspect ABPA, which is allergic bronchopulmonary aspergillosis. So the total IgE here would become factor for diagnosis along with the other radiological diagnosis, skin prick test, IgG to aspergillus. So this is an exception because it's a poorly controlled asthma. And another exception is you think that, this is an allergic asthma and you would want to try omalizumab because it's maxed out on the inhaled corticosteroids, right? So in this case scenario, probably you would want to try omalizumab and to see if it is going to, benefit the patient, you might want to order a total IgE and see. All right, these are the exceptions. So do we add any other allergy test in this scenario? Because a total IgE was already ordered by a pediatrician, which has come to us. See, this particular patient would definitely benefit from skin prick test or aeroallergens or to, specific IgE to aeroallergens. Like I think Dr. Alok has mentioned it very well that this becomes a comorbid feature, right? Allergic rhinitis would be a comorbid feature for poorly controlled asthma. So 70 to 80% patients might have concomitant allergic rhinitis, which I'm sure Dr. Madhavi is going to tell you more about in the next talk. So the reason for this slide, I'll tell you. So the increased total IgE is seen in several conditions, in allergic diseases, some primary immunodeficiencies, parasitic infections, viral infections, certain inflammatory diseases, and malignancies. There's a huge, big list of diseases. The chart. I don't want to present the chart and tell you, allergic disease, this, and some primary immunodeficiencies and all. So the intention here is, it is total IgE is high in all these cases and more than this. So it is of no significance to us ordering a total IgE unnecessarily. Levels of IgE is also not same throughout all the ages. It increases from birth, peak at early adolescence and drop by 18 to 19 years of age, and then it becomes stable, pretty much stable. So this is the end of the talk here. I'm just going to emphasize on the take-home message here. So again, many conditions, both allergic and non-allergic disorders, may present with elevated levels of total IgE. And even normal population may have values above the normal range, whatever is mentioned in the lab reports. And vice versa, children who truly have allergic disorders might have normal IgE levels, total IgE levels. All right. So because of this huge overlap between atopic children, non-atopic children, and normal children, total IgE is not helpful, and many times it leads us to crossroads. It leads us nowhere. And the few exceptions I've told you, right? In severe infantile atopic dermatitis, when you think foods might be the reason, then to compare it, and also when you suspect ABPA. So those might be the few exceptions where a total IgE might be helpful. And specific IgE to foods or aeroallergens should be ordered only in the context of proper clinical history. Because in the second case, I've told you that food allergy panel was done, and if it is going to be positive, then the child would be devoid of all those foods. The parents are not going to give those foods. So we explain to them it's only sensitizations, they're not going to listen, and unnecessarily they're going to avoid all those foods. So I'm sure, like, if me, you, and all of us present here would get a food allergy panel of maybe 30 or 40 done, at least 4 or 5 would turn out to be positive. But we would be having it all through the life. So it's only sensitization and it's not clinically true allergy. So it's better not to get it only done, right, if it is not indicated. And so not just by the numbers or classes that is given with the report, but a proper knowledge of interpretation based on specific foods and ages required here. And as always, to confirm food allergy, the gold standard is double-blind, placebo-controlled food challenges in the hospital. And we do have standard protocols to it, wherein we do have a nurse who takes care of it, who have a dietitian to support us. We have a team to conduct the food challenges. And the hospital should be able to handle, I mean, the setting, wherever it is, even if it's a clinic, but it should be able to handle emergencies in case of reaction or anaphylaxis. If at all, we'll have to do the food challenges. So again, I thank you all for being very patient and listening to this talk. If you have any questions, please feel free to
Yeah,
answer.
thank you so much, Spurti madam. It was a lucid presentation. I hope you have well described the role of IgE by various case scenarios, madam. We'll take up some of the questions.
Thank you, ma'am.
I could see lots of chatting in the chat box, madam. I think many of the questions were already addressed by Jekka sir and.
I think Dr. Spurti, you can look into the chat box and keep answering the questions for lack of time. It was a good presentation. The only take-home message which I would give to the pediatricians is just don't go by the report, look at the patient. Go by the patient and clinical presentation and then relate it with the report. That would be much better than going by the report. And all IgE, high IgEs don't mean that they are allergic. Fine, thank you, Spurti. I think, madam, you can go ahead with the next.
Yeah, sir. We'll move on to the next session, sir. It was a topic on. Next topic is an unusual presentation in allergy, which will be dealt by Dr. Madhavi, madam, who is a consultant pediatrician and allergist at Continental Hospital. She's a national faculty for pediatric allergy conferences and CMEs. We are eager to hear to you, madam. Over to you, madam. Dr. Madhavi, madam. May I request you to please share your screen, madam? Yeah.
Dr. Madhavi, you're now a co-host. You can unmute yourself.
Can you hear me now?
Yes, ma'am.
Yeah.
I'm just sharing the screen now. Okay. I'm going to talk about the unusual presentations of allergic rhinitis, which was a topic given to me. From what my clinical experience goes, the commonest presentations I've been seeing for the last couple of years since I've come back to India are mainly food allergies, urticaria, and allergic rhinitis. The allergic rhinitis has unfortunately the incidence has gone up a lot, and most of the patients are presenting with different varied symptoms, especially with the comorbid symptoms, which I want to stress as because the general obstetricians are the first mode of call for these patients. Okay. I'm going to go through the cases first, and then what we'll do is we'll go through the general allergic presentations. So people are aware of the different ways the children present to us. All the cases I'm presenting here are the cases are the real cases which I've seen in the clinic. So this is a 10-year-old boy who was presented in the clinic with history of frequency of headaches for the last 3 months. They have been to their family doctor, who said it could be just due to the online classes these children are attending, and asked the mother to get his eyes checked. Got the eye check done, which was completely normal. And then mom, who's a psychologist, was very much worried and went to a pediatric neurologist next because he was still complaining of headaches. The investigations and the examination by the pediatric neurologist was again completely normal. As the mother mentioned sneezing in the history to the pediatric neurologist, she wanted me to have a look at the child just to see if there's any associated rhinitis or sinusitis. So I'm going to touch these cases again at the end. Meanwhile, I just want the audience to think about them. So what else would you like to ask in the history? How do you proceed in this case? So just have a think over about it, and after the presentation, we'll touch these cases again, and hopefully you can answer them yourself. The case 2. 6-year-old girl was brought to the clinic by her parents. They are concerned about the frequent colds she's been having. This is the commonest presentation we have been seeing with the general pediatricians as well, where parents come, especially the preschool children, is having a lot of colds. There's something not right with him. So how do you go about these cases? In this particular case, there was history of bouts of sneezing and constant nasal block as well. Mother also had concerns about her chronic dry cough, which is something which we have to keep at the back of the mind, because we are thinking, is it postnasal drip or is it something to do with asthma? Dad has history of asthma. Again, so just to have a thought about it, what are the differentiating features between the common cold and the allergic rhinitis? This is the commonest scenario we all face in the clinic. And what investigations would you like to request? And how are you going to manage this child? As I said, have a think about it, and at the end, we'll come back and sort of discuss about it. This is one of the cases I saw in UK in my allergy clinic. 15-year-old asthmatic boy referred by the general practitioner due to his worsening asthma. As I said, he's a known asthmatic. He's on inhalers, and the GP rightly checked his inhaler technique and everything. But in spite of which, his asthma was worsening, had hospital admissions. So he was referred to our clinic. So history is that he's having problems sleeping due to stuffy nose, and his parents say that he snores a lot, has a bad breath, and is constantly sniffing. And his symptoms are worse in summer, associated with conjunctivitis as well, just during that particular season. And they have 2 cats and a dog, and they live in the countryside. So what are the potential causes of worsening of the asthma? And again, this is another scenario where you are doing the right treatment and everything, but the patient is not responding. So you need to think out of the box to see what are the causes for these, and what are the investigations and treatment options we have. Okay, so just going to the background, just going to touch base the general outline of the allergic rhinitis, which is relevant to our practice, and then we'll go back to the cases and then discuss about it. So allergic rhinitis is basically IgE-mediated inflammation of the nasal mucosa. And allergic rhinitis consists of early and late phases due to the release of various chemical mediators from the mast cells. So when the aeroallergen is exposed, the IgE in the sensitive person gets sensitized and it binds to the mast cells. So whenever the next exposure happens, the mast cells basically release all the chemical mediators, leading to the early phase. And the early phase mainly consists of itching, rhinorrhea, and watery runny nose. The late phase, which sort of happens 4 to 6 hours later, is due to the recruitment of the eosinophils and the basophils, which basically release other mediators, other chemical mediators, which causes the nasal block or the nasal congestion at a later stage. So allergic rhinitis, as we all know, is a risk factor for asthma. Currently, what they say is 70 to 90% of the asthmatic patients have allergic rhinitis. And vice versa, allergic rhinitis, about 40% of the patients have asthma. This is a general incidence from all over the world. And obviously, it varies from region to region and from different continents as well. And again, it's a general figure where it affects 10 to 30% of the population worldwide. According to the CAREST survey in Indian patients, which is basically a survey which was done in 2019, which looked at coexistent allergic rhinitis and asthma. And it was done in 10 cities all over the India, where they collected the information and they sort of looked at the data and everything. They found that the incidence of coexistent allergic rhinitis was about 65% on the whole. And unfortunately, highest prevalence, about 80%, was in South India, followed by the West India, which was about 60%, and then North India 50% was about 50%, and 40%, the minimum, was in the northeast of India. But South India has the highest prevalence. So comorbidities. The reason I want to touch the comorbidities is, as I said, these are the other symptoms the patients tend to present in the clinic rather than the actual symptoms of the rhinitis, which they may or may not tell the doctor when they present to the clinic. So the general ones are sinusitis and other symptoms with tonsillar and adenoidal hypertrophy, where mom says mouth breathing or snoring. And there are issues about hearing, speech problems, and serious otitis media contributing to that. And there are younger children, because of these issues, where they can't actually express, can present with behavioral problems. So it's something to sort of keep at the back of your mind. And obstructive sleep apnea, asthma, as we already discussed, and learning problems because of the fatigue and somnolence which they have in the daytime. They don't concentrate in the class, and the schoolwork is affected. So in the history, what are the salient features we ask in the history? As I said already, it's about itching, rhinorrhea, sneezing, nasal block, red eyes or conjunctivitis, eczema, earache, frontal pain or headache, again related to the sinusitis, snoring, cough, wheezing, etc. So in the history, what we need to ask is it perennial, indoor, seasonal, outdoor? The perennial or the indoor, generally we need to think about the dust mites, pets like dogs and cats, insects like cockroach, and obviously molds as well, which is generally the cause in the higher humidity areas. Outdoor or the seasonal, you tend to think about pollen and sometimes even molds. And the triggers, you need to ask them what are the triggers. In some cases, it can be just sort of irritant triggers like strong smells. And the other thing we need to stress about is the family history of atopy, where we do know that the monozygotic and dizygotic twins, which I give you an example, the monozygotic, they tend to have a 65% preponderance compared to the, the monozygotic tend to have a higher incidence compared to the dizygotic. And obviously, if the one or both the parents have the history of atopy, there's much more increased incidence in the kids. So we tend to ask about the family history of atopy as well. Ask about the quality of life. Is a child able to do day-to-day activities? How is his schoolwork? Is he sleeping well in the night? And other things. Examination. These are the ones which most of us are aware of, but just to sort of go through them again. Allergic shyness or the dark discoloration below the lower eyelids, which is basically due to the venous congestion. Allergic crease, which is a transverse crease along just beyond the tip of the nose because of the constant rubbing. Allergic salute, where the palm of the hand is used to rub the nose, so it opens up. Dennis Morgan creases below the lower eyelids. Bunny nose, which is because of the constant itchy feeling, their constant twitching. And anterior rhinoscopy shows pale boggy turbinates in the nose. So the classification, this is a sort of a broader classification. The first and the second one are the common things which we see in children, which is the allergic and the infectious rhinitis. The other one, which is a non-allergic, which includes your hormonal drug-induced irritants, vasomotor, are less frequent in children. And the classification is very important because as we know, the allergic conjunctivitis and rhinitis is IgE mediated, which can be proved with the skin prick test or the specific IgE, and the treatment is given accordingly. Obviously, for the infectious rhinitis, all these things don't apply. So investigations are mainly clinical diagnosis based on the history and the physical examination. However, as Dr. Spurti has already discussed, the IgE type hypersensitivity can be recognized by skin prick tests, but mind you, we need to have standardized reagents for that. And if we have that, it's a very sensitive, rapid, and effective test. Total IgE, again, as Dr. Spurti mentioned, total IgE is not helpful. Specific IgE can be done if we don't have access to the skin prick tests or if it's contraindicated because of different reasons which we have already discussed before. So management. Management depends on the severity of the symptoms and the duration. The area or allergic rhinitis and impact on asthma classification basically tells you to sort of divide them into mild, moderate, and severe, depending on the symptoms. So as we said before, is the child sleeping well? Does he do normal activities? How is the school function? How is he sleeping at night? With that, you categorize it's a mild, moderate, or severe. And depending on the duration, you say it's intermittent or persistent. So intermittent is less than 4 days per week for less than 4 weeks. Persistent is more than 4 days per week for more than 4 weeks. So management. Management is basically on these 4 pillars, which is the patient education, prevention of exposure to allergens and irritants, and pharmacological therapy and immunotherapy. Allergen avoidance. So just sort of briefly going through this, dust mites, you ask the parents to use allergen impermeable bedding covers, carpet removals, avoid soft toys, vacuum with HEPA filter, washing clothes in hot water, dusting with damp or the moist cloth. And for the pets, try and get rid of the pets. If you can't, then have pet-free zones, and frequent vacuuming helps. Saying that cats are quite notorious, where they say that up to 6 months, their allergen extracts still sort of linger in the house. Just be aware of it. Allergen avoidance to continue, the mold loves humidity, so try and reduce the moisture control in the environment and use dehumidifiers. Colon, keep the windows closed during peak season. If we do need to get out, wear the masks and goggles, and when you come in, change the clothes and shower. So this is a general sort of a treatment which is recommended, which is depending on the severity and the duration again. So for the milder ones, sort of oral antihistamines with plus or minus decongestant for a short term should work. For the other ones, which are the persistent or the moderate severe ones, you tend to think of other things like nasal steroids, local chromones, and the worst case scenario where there is a failure of all this therapy, you tend to think of immunotherapy. The simplified treatment I tend to follow is where if the complaint is nasal congestion or the nasal block, you think about intranasal steroids because they're quite effective, plus or minus the decongestants. Intermittent episodic with sneezing, itching, and rhinorrhea, oral antihistamines work very well. Even for the milder symptoms, you think of oral antihistamines. Moderate to severe symptoms, the first line is intranasal steroids. Sometimes if it doesn't work, combine it with intranasal antihistamines because the dual therapy is supposed to be more effective than the monotherapy with just the intranasal steroids. Pharmacotherapy. Again, most of us know about this, but just sort of go through it briefly. The first generation, not preferred because of the side effects of sedation and cognitive impairment. Second generation, like fexofenadine, bilastine, loratadine, cetirizine, are long-acting and non-sedating. Fexofenadine and bilastine are very good non-sedating agents. Loratadine on higher doses can be sedating. Again, cetirizine in normal doses in some patients can be sedating. Intranasal antihistamines like azilastine have a very good effect compared to the oral antihistamines. They tend to act quite fast within 15 minutes, but the only problem is the taste disturbance and the irritation, which the patients don't like. So intranasal steroids, as I already mentioned, is the first line for the severe and the moderately severe persistent symptoms. Intranasal decongestants are quite useful, but generally use it only for less than 10 days. I tend to use it when there's a really lot of congestion in nasal block and there's a problem in absorption of the intranasal steroids. I tend to keep the decongestants for a few days so that the intranasal steroids absorb better. Anti-leukotrienes like montelukast are generally preferred in seasonal allergic rhinitis with concomitant asthma. Them on its own are not any more effective than antihistamines, and they're not as effective as intranasal steroids. Other things to think about are chromones, which is the mast cell stabilizer. Again, problem with that, the frequency should be like 3 to 4 times. So the complaints is a problem. Anticholinergics like ipratropium are pretty good if rhinorrhea is a big problem. And saline irrigation or the saline sprays are quite effective, especially in the very younger kids where you can't really use a lot of medications. So this is a chart which basically sort of gives you a synopsis of the different effects of the medications I've spoken about. As you can see, the intranasal steroids are very good because they act on all the symptoms, which is the sneezing, rhinorrhea, obstruction, itch, and histamines They act on most of them except for the obstruction, and decongestants just on the obstruction. Chromones and anti-leukotrienes have a moderate effect. Anticholinergics mainly for the rhinorrhea because they decrease the secretions in the nose. Immunotherapy is very effective in modifying the course of allergic rhinitis, reducing the it modifies the progression to the asthma and prevents the newer sensitization to newer allergens. Recommended in patients where the symptoms have not improved despite the maximal drug therapy. Okay, coming back to the case discussions. So the first case where the 10-year-old boy with the frequent headaches presented to the clinic. When I took the detailed history, they actually said that he has always had nasal block for a long time, in fact, for 5 years, and has sneezing and watery nose, mostly in the mornings, but sort of never
Dr.
Madhavi,
much. Dr. Madhavi, can you wind up fast because already
so he has taken
minutes.
Montico kid in the past with some relief, and he was positive for dust mites and pollen, and started on intranasal steroid and advised about avoidance. So second child with frequent colds, differentiate between cold and rhinitis. Cold is generally for 10 days and with fever and malaise. Itchy eyes, think about rhinitis. Positive for dust mite, again started on INS, allergen avoidance was suggested. Also tested for asthma, negative. 15-year-old boy with worsening asthma, positive for grass pollen and dog, and started on Montelukast, asked to avoid the dog along with INS. He was later started on Grezac sublingual immunotherapy, which is available in UK, as there was no improvement. Key messages: history is very important for diagnosis. Topical nasal steroids treatment of choice in severe to moderate. Treatment failure, check the technique. Immunotherapy is effective in modifying the disease. Thank you very much for this opportunity. And as William Osler said, listen to your patient, you'll get your diagnosis.
Yeah, thank you, Madhavi, Dr. Madhavi. A very good lucid presentation. And from one question, throw light on fexofenadine shortly. Dr. Ramesh had asked about the question. Fexofenadine, role of fexofenadine.
Fexofenadine is very good non-sedative agent, and the sort of you can it is licensed to prescribe from 6 months in urticarial patient, but for the allergic rhinitis, for some reason, it's from 2 years onwards. And the safety data is pretty good. And some of the studies have said that you can give it until 15 months.
Okay. Thank you. Thank you so much. And very good presentation by Dr. Kedar, Dr. Spurti, and Dr. Madhavi. I think very good case presentations, which will definitely help in day-to-day practice of the pediatricians. And now, can we move on to the next session, Suman?
Yes, sir.
Yeah, please take over. Please take over.
Try to take on. Thank you, sir. We are just coming to the end session. I thought we would have a debate in the end just to keep it interesting. This is a simple topic, straight away topic of atopic dermatitis. The challenge is steroids the only treatment? Are there any alternatives to it, and how best the alternatives are? So two people are going to debate. This is experience versus non-experience, means the inexperienced. Dr. Anand Vani, who has just passed out his allergy from DA CMC Vellore, will be challenging the most experienced, Dr. U. Narayan Reddy, who has handled hundreds and hundreds of cases out here. So let's see how interesting the case scenario would be. So Dr. Anand Vani, who is a pediatric allergist at Lotus Hospital, I would first welcome him to take on the first debate, please, first part of the debate. Anand, are you there?
Anand, you're a co-host now. You should be able to unmute.
Yeah. Good evening, sir. Thank you, Dr. Suman, sir, for giving me this opportunity. As sir has rightly said, till now we have seen all the experiences and the case series, And now we'll just have a quick look on the data which is available and what the study says presently. What are the studies available regarding the newer management?
Anand, just sorry to interrupt. Your time is only 7 minutes for the
Sure,
presentation.
sir.
Try to
Sure.
keep it within 7 minutes, please.
Sure, sir. I think now the screen is shared with you.
Yeah, it's shared. Good.
Sure. So just to keep the discussion very brief, I'll just give a lot of data which is available at this point of time to treat the difficult allergic condition in pediatric like atopic dermatitis. So we'll discuss or have a, I'll just discuss my data on this 4 topic like the anatomical regions and the age where the steroids are showing the challenges where we can use it, topical immunomodulator, a steroid toxicity and its pairing effect, how we can use it, a topical immunomodulator, obviously to limit disease progression and relapses. And of course, most important is the safety and cost effectiveness. So what are the topical steroid, non-steroidal immunomodulator available till now? The licensed ones are topical calcineurin inhibitors, 0.3% and 0.1% ointment, pimecrolimus 1% cream, and topical phosphodiesterase inhibitors. They are still upcoming. They are in trial, and also some countries it is available. Slowly, it is available in India also. So, what are the challenges we face when we treat atopic dermatitis in difficult conditions, like on the face, where the lesions are moderate and severe, neck, skin fold region where the skin thickness is very less, and definitely a pediatric age group. So what are the data available till now? So when I'm going through the data, I got some of the reviews and some of the analysis, meta-analysis. So one of the meta-analysis showing this, that, yes? Yes. So one of the meta-analysis shows the problem.
There is many studies in this.
Yes, yes. Yes, so I'll just brief the studies about these side effects and uses. So the prolonged use of topical steroid, what are the problem faces? The striae, pigmentations, and scars. So what are the available robust data? Is the highest level is the consensus which is available to us, and consensus I could found is European consensus, the Asia Pacific consensus, and the consensus Italian consensus saying that the safety of tacrolimus over the steroid in the using difficult areas like near the eyes, face, and pediatric age group. The next challenge what we face is the steroids toxicity and disease severity. So what are the evidences available? So when I'm going through the journals, I get this meta-analysis which nicely depicted that moderate to severe atopic dermatitis is very well managed and as effectively as managed by the potent corticosteroid when it is used with the tacrolimus. And when the pimecrolimus is considered, it is a good value in the long-term maintenance of the treatment. Another evidences is from the BMJ, which is very old journal, trusted journal. It also says that topical tacrolimus has a similar potency in treating the long-term cases of atopic rhinitis, which are resistant. Then another meta-analysis to support the same. Now when the cost effective.
We'll put elf fingers. We'll put this, that, and
Somebody is. I am getting some questions, or it is a noise in the background.
Right.
So there are some studies which I got it, which says about the safety and cost effectiveness. The further references, as I said, it is from the European countries. And the most important is the safety and cost effectiveness. And the most dreaded complication is about the tacrolimus is everybody's talk about the malignancies. But this is the robust review which I have found out and it is easily available. It says there is no strong evidence with the increased rate of malignancy when it is treated with tacrolimus, and the carcinogenic potential is less. Now, when we talk, the most common question comes, what about the Indian data? So when I looked at, I got the good data in the Indian scenario, which says that when we use the tacrolimus of 0.03% in Indian population, in moderate to severe atopic dermatitis, it has as good as effect compared with the mild and or the potent corticosteroid. And when we use it for the long term, the side effects with the steroids are very less. This things is supported by the further Indian references, which is done by Dr. Sandeep Dar and his Department of Dermatology and the Pediatric Age Group, which is freely available. I just enumerated that. So to conclude my part in this session, I'll summarize what I could make out from all the analysis and meta-analysis and the consensus, which are the higher level of evidences which is available now. The tacrolimus ointment is used in the moderate to severe forms with the 0.03% formulation in pediatric age group as potency and effectiveness in pediatric age group from 0 to 15. For pimecrolimus, 1% is very good from 2 years onwards, and even there are some experiences which will come, and this is why not to use a steroid when it decreases the itching and irritation in a pediatric group. So that time we get a good support that if you are using a steroid to minimize its dose toxicity, topical immunomodulators are a good add-on therapies in mild to or moderate to severe atopic dermatitis. I'll just try to stop here and I'll keep it open for a discussion if any doubt.
Thank you, Anand. I would now counter it. What he says is tacrolimus and pimecrolimus is much better choice on a chronic atopic dermatitis to be given on a long-term basis, especially in the areas of face and intertrigal areas where atrophy of skin is more common. So Narayan Reddy sir, you can take over. The debate. Dr. Narayan Reddy is the most experienced pediatrician out here, and he is also a practicing pediatric allergist. He is also a central EB member and also the president of allergy chapter of Telangana. Sir, kindly take over. Sir. Narayan Reddy sir, you can unmute yourself and you can take over, please. Kindly unmute, sir. Yeah, go ahead.
I'm audible.
There is a lot of echo, sir. There is a lot of echo.
Hello?
Narayan Reddy sir, you need to unmute or you need to disconnect from the other device in that room.
Use only
if you have two devices in the same room, the echo comes out. Yeah, it's better now, sir. Please go ahead.
Hello. Good evening, everybody. I'm visible, audible.
Yes, sir. Yes, sir.
So thanks, IAPTCB,
Yes,
for giving me opportunity. Today is my last topic for today's session. After starter, main course, last dessert, ice cream is more important. Okay, all are hungry, I think, to eat ice cream. Okay, I will be talking on topical steroid in atopic dermatitis. Next. The atopic dermatitis is characterized by itching, exudation, crusting, and scaling with chronic relapsing course. Is very important. And first manifest in young infants, leading as a gateway to allergic march. It starts in infants. So there is a gateway to allergic march. If we don't control atopic dermatitis properly, if you don't treat properly, it may go into allergic march, going to asthma, allergic rhinitis, other allergic diseases. So proper management at the earliest is necessary to improve the quality of life and prevent allergic march. The role of topical steroid. Topical steroids are very effective in first line of therapy in controlling inflammation in atopic dermatitis. It can be used safely in infants. So others like non-steroidal topical applications are recommended about 2 years. But here you can use in infants as young as 6 months, 3 months also. So type of steroids used depends upon the severity of disease. If it's more severe, older child can use only strong one, moderate, severe one. But mild steroids are recommended most of the time in infants. Age of the present patient, location of the lesion, type of preparation, that depends upon when to use, what to use. Sufficient dose, strength, correct application of topical steroid should be used. That is a very important point. So it is important to continue moisturizer along with the topical steroid, because moisturizer is the main therapy, but that is the first line treatment. So first, liberal moisturization that use liberally. So after bath, afternoon, night also, liberal moisturization is important, because they have to break the cycle of each scratch cycle. So these are the topical steroid available: mildly potent, moderate potent, highly potent, super potent. But in children, most of the time, mildly potent is very important, particularly over the face, neck and groins, where you use mildly potent, particularly hydrocortisone, progesterone, or moderately potent, destonate, mometasone, fluticasone can be used in, over the chest and lower limbs. But mildly potent use recommend most of the infants, particularly younger child, particularly over the face or the eyelids, neck, groin region. That is one thing. Reactive therapy and pro-reactive therapy. Reactive therapy means here when there is acute inflammation, flare-up is there, use topical corticosteroid 1 or twice, not more than 2 times, only once sufficient in the evening time, and should use 1 to 2 weeks. Once the inflammation, the flaring has come down, go to proactive therapy. Proactive therapy is very important to suppress it, to prevent reactivation, flaring up. So what is called proactive therapy? When it is improved with the reactive therapy. So topical steroids are used twice a week, once in 3 days, on affected area of the skin during remission period to prevent exacerbation. Can be used for 3 to 4 months. By this, you can prevent the exacerbation. That is called proactive therapy. So method of application: topical steroid should not be applied more than twice a day. I told already, once a day more than sufficient, and should be used 1 to 2 weeks continuously. Continuously use 1 to 2 weeks, not more than 2 weeks. And of course, proactive therapy can be continued for 3 to 6 months. So amount to be applied can be explained to the parents in the form of fingertips units, whereas 1 finger to be equivalent to 0.5 grams. Topical steroid work well when applied to wet skin. These are fingertips. The fingertips, particularly face and neck, use very minimal amount, 2.5 fingertips. A trunk and abdomen can use more. Legs can use more. So what the neck and face should be very careful about the topical steroid, because to avoid complications, side effects. So tapering up topical steroid very important to prevent complications, side effects, particularly either switching over to moderate then mild steroids, and decreasing the frequency of use should be followed. So once acute flare-up is subsided, you go proactive therapy. Topical steroid to be reserved for acute flares only continuously. So decrease the side effect. If you proper dose, proper formula, definitely can prevent complications. So that is an hour. Particularly if you are using vehicle, so you don't use 120, 160 kilometer may accident. So use depends upon the condition, flaring up, and use mild to moderate steroid in children particularly, and should be very careful over the face, neck, groin region, where to prevent complications. See, these are the common complications you see in steroid, topical steroids, but the cutaneous complications and then systemic complications. Very rare if you use appropriate with mild steroid, so definitely you have less complications. These are the you rarely see complication. If you abuse the steroids, if you use overuse it. So if you go on prolonged period, if you high potent steroid use, definitely you have complication. If you mild steroid, if you careful and quantity use, and also period is important where to prevent the complications. So take home message: topical steroid is a first line of therapy in atopic dermatitis, can be used in as young as infants. Safe and effective, be used in appropriate dose and duration. Very, very important. This is very careful, because steroids should be double-edged sword. It's very useful. If you misuse it, it has side effect like a salt. If you use more use, you deteriorate the whatever item will be, we cannot eat. So you have to be very careful. Use appropriately. A mild steroid should be used, and it is a duty of the treating pediatrician and dermatologist to treat atopic dermatitis effectively to improve the quality of life and prevent from from the leading to atopic march. I told you the atopic dermatitis is the allergic march. From here allergy disease starts. If you treat appropriately, flaring up so many, most of the time allergic atopic dermatitis flaring up for maybe skin infection like staphylococcal infection, viral fungal infection has to be treated before starting corticosteroid, because corticosteroid if we use without treating flaring up like skin infection, where it may exaggerate skin infection more increase. So other flaring up I already discussed earlier, food allergy, milk allergy may be flaring up. If you do immunocap, where if milk allergy is there, comic allergy, if you prevent it, we give immunotherapy, you can prevent the atopic march, you can flaring up can be decreased, the severity can be controlled. Even aero allergen, dust mite may be there, sometimes exaggerating factor. That's why you have to always try to find out the exaggerating factor, flaring factor, not is just steroid. You have to detail history and you have to determine the flaring up particularly skin infection or food allergy or air allergen. If you determine, avoid, sometimes immunotherapy can definitely decrease the flaring up and improve the quality of life, and you can halt the atopic march. So complications can be prevented easily by cautious use of appropriate strength and duration. It's very important to prevent complication. Thank you.
Sir, for an elaborate and finishing it on time. I think just to brief it up, as far as the debate is concerned, any child below 2 years, steroids and moisturizer creams are the only treatment. There's nothing else of a choice. Beyond 2 years, especially for moderate to severe atopic dermatitis, where the steroids have to be used for longer duration of time, and especially on the face and in the axilla, these are the regions where we prefer initially to start off with steroids and then to start off with tacrolimus on a long-term basis. So we call it as a rotational and a regional device method, which can be followed. Thank you all for being a part of this, and I would ask Sri Krishna to take over, please, as far as the presentation is concerned.
Thank you, Dr. Suman and the entire team.
Thank you, sir.
It's been a wonderful CME, finished dot on time, and extremely enlightening sessions over the last 3 hours. Thank all the faculty for sparing your time and excellent knowledge. May I now request Dr. Yashwant Rao, Sir, Central IAP EP member. Sir, if you're around, please say a few words before we close.
Thank you, RSV, for giving me an opportunity. I've been following since last 1 hour. It is a most part is from Dharma module of the Central IAP. I haven't been in the 1.5 hour, but Narayan Reddy sir or Anand Vani and all those have really been to the point in their talks. It was a very lucid presentation. Thank you.
Thank you, sir.
Thank you, sir.
Convey regards from Dr. Narahari as well, the Central IAP EP member from Telangana, and of course, Narayan Reddy sir as well. Thank you, everyone. May I now request Suman to give closing remarks, and we'll be able to end the session. Suman, over to you.
Yeah, thank you. Just to close off with, I'll start off with a point which I've started off with. I'll end with the same point. Allergy is a part of pediatrics, and it is only going to increase over a period of time, whether you're practicing in urban or rural area. Now the lifestyles have changed, the patterns have changed, and there will not be a day without you seeing or managing a case of allergy in future. It's better we enlighten ourselves, we sensitize ourselves, and it's not that difficult to manage a case of allergy. It's not that complicated. All we need to do is go to the basics, get a brief good history done, evaluate the patient well, and counsel the patient well, which becomes an important aspect of management of allergy. And then comes the diagnostics. Diagnosis comes really later. And as far as the complications of immunotherapy and all, pediatric allergists are available to manage, and the complicated diagnosis of food allergy, pediatric allergists are available to manage. But 90 to 95% of the allergy cases, most of the general pediatricians, wherever they are, can easily manage. That's what was the agenda for this meeting, is to identify, sensitize, manage, and get our practices much better. Thank you all for being on a Sunday, taking your time out despite a match going on between India and England. And I wish you all the best. Thank you.
Thanks, everyone. The session is also live on YouTube, and we'll be sharing the link with all the IAPians. So those who have not been able to watch it live can again see the sessions. Thanks, everyone, and look forward to your active participation in the upcoming Vaccine Decon, jointly hosted by IAPTCB, PATS and the IAP ID chapter of the Telangana state. Request you all to please come down to the auditorium of Apollo Institute of Medical Sciences. All due COVID precautions shall be taken, and I'm sure, as our president said, if you're safe at your workplace with COVID around you, I'm sure you'll definitely enjoy the academic sessions and the hospitality of IAPTCB and PATS at Apollo Medical College. Look forward to hosting you at VaxIndicon exactly in a week's time. Thank you for your active participation in all IAPTCB activities. That's all for tonight.